Our worthy director, Dr. William Bhatti, Dr. Rajiv Sood, Vice Chancellor, Baba Farid University of Health and Sciences, Faridkot, and today's Chief Orator, Dr. Jairaj Pandian, Principal, Christian Medical College, Ludhiana, Dr. Alan Joseph, Medical Superintendent, Christian Medical College, Ludhiana, Dr. Karamveer Goyal, PMC Member, Dr. Navneet Kumar Chaudhary, Secretary, Dr. L.H. Lobo, Ludhiana Trust, Dr. Maninderjeet, President of Dr. L.H. Lobo Memorial Trust, and Dr. Tarun Satija, Treasurer, Dr. Lobo Memorial Trust, Dr. Pervez David Huck, President of the Organizing Committee, galaxy of eminent urologists and surgeons, faculty, students. A very good morning to one and all. It is my immense pleasure and I extend a warm welcome to all of you at the 40th Dr. Lionel Henry Lobo Memorial Oration. With its theme on men's health and urinary tract infections. Every year, this event is conducted in the memory of Dr. L.H. Lobo. He was the professor and head of Department of Orthopedics at CMC Ludhiana. He was known for his amazing passion of teaching and his ability to mentor young minds and budding medicos. Numerous luminaries across the nation have graced this stage, and the name of Dr. L.H. Lobo continues to inspire, guide, and above all, teach all those who seek knowledge and wisdom. I welcome you all to 40th Dr. L.H. Lobo Memorial Oration.
Let us now seek the blessing from Almighty. I humbly request Reverend Alex Peter from Chaplaincy Department to lead us with a word of prayer.
Good morning, everyone. It's a beautiful morning, and we thank God that we are in God's presence. I will read from Lamentations chapter 3, verses 22 and 23. It says, "The steadfast love of the Lord never ceases. His mercies never come to an end. They are new every morning. Great is your faithfulness. The Lord is my portion, says the soul. Therefore I will hope in him." Let's bow our heads and close our eyes. Give yourself in God's hand. Every day, a new morning. Every day, a new morning is a new beginning. And that is our hope. And today when we are here, this is the day of hope. This is the day of learning. This is the day of moving forward. Heavenly gracious Father, thank you, Lord, for this beautiful day. Thank you for bringing all of us together in your presence. And especially, Lord, we are so thankful for Christian Medical College and Hospital Ludhiana, for its beautiful legacy of mentoring young people to serve you and guiding them to go out and to serve the humanity. And in this big responsibility, we are so thankful for Dr. L.H. Lobo Memorial Trust. We are so thankful for the life of our former principal and eminent medical caregiver, Dr. Lobo. Lord, thank you for giving him in our institution. And we are also thankful for each and every member of the trust who are taking forward his legacy. And today when we are here in this 40th lectures of L.H. Lobo Memorial Trust, we are so thankful for today's our chief guest, Dr. Rajiv Sood, the VC of BFUHS. Lord, thank you for his services and his work. We give all the eminent resource people and urologists who are here. Lord, be with them, strengthen them when they lead the sessions. We also pray for the Euro quiz which is going to happen today. Lord, let it be the time of learning new things. Above all, Lord, we pray for Department of Surgery and the Department of Urology who are conducting this oration. Lord, let it be a blessing. Your word says, be the light. Lord, give us the light, so be the light in this world. In your holy and precious name, we pray. Amen. Thank you.
Well, I think that was a good start for today's day. Now, I request the choir to please come forward for the invocation song.
Light of the world, you step down into darkness. Open my eyes, let me see beauty that made this heart adore you. Hope of a life spent with you. Here I am to worship, here I am to bow down, here I am to say that you're my God. You're altogether lovely, altogether worthy, altogether wonderful to me. King of all days, oh so highly exalted, glorious in heaven above. Humbly you came to the earth you created, all for love's sake became born. Here I am to worship, here I am to bow down, here I am to say that you're my God. You're altogether lovely, altogether worthy, altogether wonderful to me. I'll never know how much it cost to see my sin upon that cross. I'll never know how much it cost to see my sin upon that cross. I'll never know how much it cost to see my sin upon that cross. तेरी है ज़मीन, तेरा आसमान, तू बड़ा मेहरबान, तू बख्शिश कर। सभी का है तू, सभी तेरे खुदा मेरे, तू बख्शिश कर। तेरी है ज़मीन, तेरा आसमान, तू बड़ा मेहरबान, तू बख्शिश कर। सभी का है तू, सभी तेरे खुदा मेरे, तू बख्शिश कर। तेरी मर्जी से मालिक
That was a wonderful performance. Thank you, guys. Let's give them a huge round of applause. Now, we would like to acknowledge the presence of respected dignitaries with the fragrance of love and respect. To start, I would like to call Miss Sharon to present a bouquet of flowers to Dr. William Bhatti, our worthy director, CMC Ludhiana, and accompany him to the stage. Thank you, Sharon. Next, I request Miss Ananta to present a bouquet of flowers to Dr. Jairaj Pandian, respected principal, CMC Ludhiana, and accompany him to the stage.
I'd like to call Miss Sia to present a bouquet of flowers to Dr. Rajiv Sood, worthy Vice Chancellor of Baba Farid University of Health and Sciences, and accompany him to the stage.
Next, I request Mr. Shashwat to present a bouquet of flowers to Dr. Alan Joseph, our respected medical superintendent, CMC Ludhiana, and accompany him to the stage.
I request Ms. Sharon to present a bouquet of flowers to Dr. Karamveer Goel, respected Punjab Medical Council member, and accompany him to the stage.
I request Mr. Austin to present a bouquet of flowers to Dr. Navneet Kumar Chaudhary, Secretary, Dr. L.H. Lobo Memorial Trust, and accompany him to the stage. I would like to call Miss Sia to present a bouquet of flowers to Dr. Nitin Agarwal, Organizing Chairman for 40th Dr. L.H. Lobo Memorial Oration, and Head of the Department of Urology, CMC Ludhiana, and accompany him to the stage.
I request Ms. Ananta to present a bouquet of flowers to Mr. Maninderjeet Singh, President of Dr. L.H. Lobo Memorial Trust, and accompany him to the stage.
I request Ms. Sharon to present a bouquet of flowers to Dr. Tarun Satija, Treasurer of Dr. L.H. Lobo Memorial Trust, and accompany him to the stage.
A huge round of applause for all the dignitaries present on the dais. Now, I request the dignitaries on the stage, Dr. Rajiv Sood, Dr. William Bhatti, Dr. Alan Joseph, Dr. Jairaj Pandian, Dr. Navneet Kumar Chaudhary, Dr. Karamveer Goel, Dr. Nitin Agarwal, Dr. Maninderjeet, and Dr. Tarun Satija to please commence the lamp lighting ceremony. वाइफ का तो वेलकम करना है। ऑन है माइक ठीक है। अब इनके विलियम सर मैं बुलाती उसके बाद तू कर लेना ठीक है। शिट में भूल ही जाती कि विलियम सर का Thank you very much. Now, I would like to request respected Director Dr. William Bhatti sir to please come forward and address the audience. Dr. William Bhatti sir.
Dr. Rajiv Sood, Vice Chancellor of Baba Free University, Dr. Jairaj, our Principal, Medical College, Shri Maninderjit Singh Ji, Dr. Tarun Stija, Dr. Navneet Chaudhary, Dr. Alan Joseph, and all other dignitaries on the dais, our faculty, guests from various places, particularly all those who have joined from outside, our orators for different sessions. I welcome you all for today's oration for Dr. Lobo Memorial. Every year we do celebrate, and many times we ask the questions why we have to do it. Reason being, CMC is 130 years old organization which has contributed towards the health, training and research. And for that, many people have contributed significantly, and Dr. Lobo is ahead of them. His contribution was immense to the people of Ludhiana. And one thing which we have to learn from his life is patient first. That's what he did when he was into clinical practice. He was in difficult situation as far as his own health was concerned, but even then, his life was committed to the patient care. That's reminding us, teaching which was relevant few years back is relevant today as well. So all of us have to learn and put patient first wherever we are. And at this moment, we are grateful to Dr. Lobo Trust, Shri Maninderjit Ji, Dr. Navneet Chaudhary, Dr. Stija for their contribution. It's not an easy task. Many times we start a good thing, but it's very difficult to carry forward. So Trust has done it for last 40 years. Regularly they are organizing. So we are grateful to you, sir, for your immense contribution to carry forward Dr. Lobo Oration. So with that, once again I welcome you all, and I am sure today's oration will be an eye-opener for all of us, because it's a common subject which everyone has to face in our day-to-day life. Thank you very much. God bless you.
Thank you, sir. Now, I'd like to request Dr. Navneet Kumar Chaudhary, Secretary, Dr. L.H. Lobo Trust, CMC Ludhiana, Senior Consultant, SPS Hospital, to come forward and deliver the welcome address.
Good evening, everyone. Good morning. Dr. William Bhatti, Director, CMC Ludhiana. Dr. Jairaj Pandian, Principal. Honorable Vice Chancellors, Dr. Rajiv Sood, Chief Guest for today's function. Shri Maninderjit Singh Ji, President of the Trust. Dr. Karmveer Goyal, Member of Punjab Medical Council, Dr. Tarun Stija, Treasurer, and other trustees present here, Dr. M.K. Mahajan, Dr. S.K. Chopra, Dr. Jhawar, Dr. Alan Joseph, Medical Superintendent, Dr. Bobby John, Head of Orthopedics, Dr. Parvez Haq, Head of General Surgery Department, members of media and press, faculty and staff from CMC Ludhiana, Christian Dental College, College of Nursing, and College of Allied Sciences, and dear students. I welcome you all on this special academic event of Dr. L.H. Lobo Memorial Trust, that is Dr. Lobo Memorial Oration. Our special welcome to Mrs. Sood, better half of our chief guest, Dr. Rajiv Sood, and we thank you for gracing the occasion with her presence. She is an environmentalist. Ma'am, thank you for coming. This year's is 40th years of Oration in continuous, and I feel hugely honored and privileged to say a few words about Dr. Lobo and about this trust. Dr. Lionel Henry Lobo did an MBBS from Stanley Medical College, Madras in 1956. And soon after, next year, he joined as a resident in Department of General Surgery under Dr. F.C. Gliston. And he was the first successful postgraduate from Department of Surgery in 1960. Later on, he shifted his specialty to orthopedics and joined Dr. Gast as a lecturer and went on to become the professor and head of orthopedics and ultimately principal of CMC Ludhiana. He was the first Indian principal of Christian Medical College Ludhiana, the post he held from 1969 to till his death, 83. Dr. Lobo was an exceptionally kind and loving person. He was a great teacher and excellent surgeon, and he was hugely popular and immensely loved by everyone who came across in his life. Dr. Lobo left this world at a relatively younger age in January 1983. And soon after his death, his students, colleagues, and friends from town felt the need to do something special in the memory of Dr. Lobo. Ladies and gentlemen, it is something very unusual to remember and to dedicate somebody in today's material life. Under the leadership of Shri Sukhpat Raiji Vadhera, luminary advocate and a close friend of Dr. Lobo, a trust was established the same year that Dr. Lobo passed away, with the aim of furtherance in medical education. Dr. Lobo's oration and CME is being held at CMC Ludhiana every year since '83, and every third year oration is held in the Department of Orthopedics because Dr. Lobo was orthopedic surgeon. Prominent doctors from India and abroad who were experts in their fields have been the speakers for this prestigious oration, and the list is hugely impressive. Our first orator was Professor B.N. Sinha from Oration Institute of Medical Sciences and the then President of Medical Council of India. Dr. Matthew Varghese, Senior Orthopedic Surgeon from St. Stephen, New Delhi, was the orator last year. This year's oration is being organized by the Department of Urology with the support of General Surgery Department, and we are fortunate to have Professor Rajiv Sood, a prominent urologist and Vice Chancellor of Baba Farid University, Faridkot. We extend you a very warm welcome, sir, and we look forward to a very enriching oration. And this oration will be followed by a scientific program in which we have expert speakers who will be deliberating on the current issue related to urinary tract infections. Trustees in this trust are from the different walks of life, and we are honored to have 4 new members of trust this year. And these are Dr. Nitin Batra, Professor and Head of Eye Department, CMC Ludhiana, Dr. Bishop Mohan, Professor and Head of Cardiology, DMC Ludhiana, Dr. Ravindra Verma, a CMC alumnus, a leading administrationist of the town and a friend of CMC, and Mrs. Mandeep Pava, who is educationist, industrialist, and trustee of SNS Pava Hospital, Ludhiana. We welcome our new member trustees as the trust carries forward the rich legacy and heritage of Dr. L.H. Lobo. We are grateful to CMC Ludhiana for its continued generous support extended to the trust to fulfill its motto. I extend special welcome to Dr. Bishop Mohan and Shri Bipin Gupta ji, Secretary of General Medical College, to grace this occasion. Once again, I welcome you all. Thank you very much.
Thank you so much, sir. I request Ms. Ananta to please extend our warm welcome to Dr. Bishop Mohan, who is sitting amongst the crowd and has taken out time from his busy schedule. I request Mr. Shashwat to also extend our warm welcome to Mr. Bipin Gupta, Secretary of the DMC College, who has joined us today. I request Mr. Shashwat to also extend our warm welcome to Mrs. Reva Sood, wife of our worthy Vice Chancellor, Dr. Rajiv Sood, who has joined us today for this oration. A huge round of applause, please. Now, I request Dr. Maninderjeet, President of Dr. L.H. Lobo Memorial Trust, to please come forward and address the gathering.
Good morning. Dr. Rajiv Sood, Vice Chancellor, Baba Farid University, Dr. Karambir, Dr. William Bhatti, Director CMC, Dr. Jairaj, Principal, Member Trustees, members of faculty, honorable guests, ladies and gentlemen. I extend to you all a very warm welcome to the 40th Dr. L.H. Lobo Memorial Trust Oration. We are completing 41 years since the inception of Dr. L.H. Lobo Memorial Trust. This trust has been holding the annual oration for the last 39 years, with the exception of 1 year when the entire country was locked down due to COVID. Dr. Lobo, in whose memory this trust was created, was an eminent orthopedic surgeon, teacher, and a wonderful person whose desire was to serve not only the people of Ludhiana, but also those from other parts of the country. It's a matter of great honor for the Trust and CMC to continue the rich tradition of holding this annual scientific program in the memory of our beloved Dr. L.H. Lobo. Dr. L.H. Lobo Memorial Trust annual orations have been delivered by very eminent surgeons and physicians in the past, and we are very glad and honored to have with us today Dr. Rajiv Sood delivering this 40th Lobo Oration. We are grateful to you, sir, for accepting our invitation for this prestigious function in the memory of Dr. Lobo. On behalf of Dr. L.H. Lobo Memorial Trust, I wish the organizers all the best and am sure today's oration and scientific program will enrich all of us. Once again, welcome you all and wish you all the best. Thank you.
Thank you so much. I request Ms. Sia to extend our warm welcome to Dr. Ravinder Verma. He's a member of the Dr. L.H. Lobo Memorial Trust. Ms. Sia to please present a bouquet of flowers to Dr. Ravinder Verma.
I now request respected member PMC Dr. Karamveer Goyal, who has taken time out from his busy schedule to be a part of this memorial oration, to please come forward and address the gathering.
Good morning to all. Chief guest of the day, Dr. Rajiv Sood, Honorable Vice Chancellor of Baba Farid University, worthy Director CMC Dr. William Bhatti, Principal Dr. Jairaj, dignitaries on the dais, off the dais. A very good morning to all of you, and I bring greetings from the Punjab Medical Council on this occasion of Lobo Memorial Oration, which is 40th, as I'm told today, and I've been part of it for last 4 or 5 years since I've been member of the Punjab Medical Council, and it has been a wonderful experience. As health professionals, I think we hold the great responsibility to alleviate the suffering, promote wellness, and uphold the traditions of empathy and compassion in our profession. And such programs are of great help in maintaining our focus, and especially the new generation. For the new generation, they gather better knowledge and share the experience of their elders in such programs, and which is of great help in continuing our endeavor for the betterment of the society in this era of social media. And we have to continue our guidelines-based medicine and keep ourselves away from all the myths and misbeliefs which deviate our path in our endeavor to deliver the best of our care to our suffering and ailment of the mankind. So today's oration and CME is one again program which will help you in adding to your already existing great knowledge. And as already declared, I announce 4 great hours from Punjab Medical for today. Thank you. Have a great, and my best wishes from the council and myself for a great conference today. Thank you very much. Thank you.
Thank you so much, sir. Next, moving on to the most awaited event of the morning, the 40th Dr. L.H. Lobo Memorial Oration. Now I request Dr. Nitin Agarwal, Head of Department of Urology and Organizing Chairman for 40th Dr. L.H. Lobo Memorial Oration, to come forward and introduce the orator, Dr. Rajiv Sood, Vice Chancellor of Baba Farid University of Health Sciences, to the gathering.
Good morning, friends. In fact, Dr. Rajiv Sood needs no introduction, and he is well-known academician and administrator. He is an eminent urologist and Vice Chancellor of our Baba Farid University of Health Sciences, Punjab. He has received more than 100 prestigious awards throughout his career. Some of these awards are prestigious B.C. Roy Award, that is the best teacher award at the national level. And he was given Lifetime Achievement Awards from Delhi Medical Association, Norjom chapter of Urological Society of India and Urological Society of India. And he has taken our society to the new heights, Urological Society of India. His contribution is vast. And he was also nominated for Padma Awards by Ministry of Health and Family Welfare in 2016. He is also member of Board of Director of Society of International Urology, and he is also president of Men's Health Society of India, Delhi Urology Society, and Urological Society of India. He has over 45 years of experience in urology and kept himself updated with current trends, and best of that being an excellent robotic surgeon. And he joined as Vice Chancellor Baba Farid University, and he established good department of Faridkot Medical College. So Dr. Sood, आपके आने से जो हुआ जो उजाला है, आपके आने से हुआ जो उजाला है, लगता है कुछ होने वाला है. Thank you very much, Dr. Sood.
I request the dignitaries on the stage to please take their seats in the audience so that we can begin with the oration. I request the dignitaries to please join the audience so that we can begin with our oration. I invite Dr. Rajiv Sood, Vice Chancellor, Baba Farid University of Health Sciences, to deliver his talk on men's health.
Good morning, everybody. Today I feel it is my proud privilege that I am amongst you. It is not something new that I am in CMC Ludhiana. I had been coming for long, but I am thankful to Dr. Nitin for nice words. I acknowledge that Dr. William Bhatti, Dr. Jalal Pandian, Dr. Joseph, Dr. Kamvir Goyal, Dr. Vish Mohan, our Board of Management, all the dignitaries on and off dais are there, President, Secretary and Treasurer along with other trustees are there. I can see Dr. Kim, my old colleague, and Dr. Vipul, Dr. So many dignitaries are there. It is really wonderful, and it is wonderful to be amongst you. This is the month of November, and November is Men's Health Month, and it is also called Movember. And the theme of this year is to create men's health champions. And to create, this is a new specialty, not very old, maybe 10 years it is flourishing, and it is only 20-year-old. It is by back integration. I'll take you through the journey that why this is important and why this is now the established, becoming established specialty, and why we should have it. So when we started, I'll pay my respect to Dr. Lobo, and this is 40th oration, and I think it is Ruby Jubilee oration, 40th. So this is a great moment that former professor and head Department of Orthopedics, CMC Ludhiana, who was known for his amazing passion for teaching and ability to mentor young minds and building medicos. Dr. Lobo was the first successful postgraduate candidate we have learned, and his untimely demise is cherished in the memory through the annual Lobo Memorial Oration. The name continues to inspire, guide, and above all, teach all who seek knowledge and wisdom even after 41 years. And passion doesn't need a reason. And when we talk about men's health, or we talk about a gender-based discussion on the medical subject. So it is basically aging, which is happening very fast in men. And because the male, even at the cellular level, they are energy spending cells and they die earlier. And the man is dying earlier than female, suffering more physically. Morbidities are more and the results of morbidities is also worse. Like lung cancer is in male, female both, but it is more in male, and it is, if it is happens, the response of treatment is bad compared to female. And similarly, the COVID we were talking about, COVID was around 67 to 70% in male, and it was 30%. HIV, hepatitis, you talk about anything, these psychological problems, suicides, 3 times more in male. So male, there is some problem. And it is, yes, it is active aging. The aging, what happens when the people age? There is an active aging model, and World Health Organization has taken 4 key pillars for that: lifelong learning, participation and security, to develop their potential for well-being, all senior citizens, and which in turn may facilitate longevity. Now we are focusing on longevity when we are talking about gender-based medical discussion. People tend to fall into one of the 4 biological aging pathways. These are called agiotypes. You age according to immune system that is exhausted. Kidneys are important. Liver is important, and metabolic syndrome, which is damaging everything. So these are 4 different ways of aging, and the Cohen's 4th stage of maturity, we call it midlife crisis, and it is midlife re-evaluation. That is the time when you have to get yourself re-evaluated, especially in males. And then the phase 2 is the liberation phase, 50 to 70. Summing up is the 60 to 80, and final phase is encore ages later than 70 until the end of the life. So these are the 4 phases of the life. And why I am talking about aging, because it is very closely associated with men's health, and it is special attention is needed for men compared to women. Both gender need attention, but men need special attention after the age of 70 at least. And there has to be age-friendly environments. Combating ageism is important, long-term care and integrated care. Why I say integrated care? Because there are so many specialties. You start counting, it may be 20, 30 you will count, but you will not be able to care unless you back integrate all the specialties. And we are specializing, super specializing, subspecialties, but now we have to back integrate to care for the male. And the challenges are ageism or self-care. Male is careless about himself compared to female, and therefore it is important. And also there is a prejudicial attitude, discriminatory practices are there against older people, and institutional practices and policies, even governmental policies, are not very helpful for the male gender. And ageism is a stereotyping and discrimination against individuals or groups on the basis of their age. This may be casual or systematic. It patterned on sexism or racism. And self-care, I have already explained, that is very important. And hygiene, nutrition, lifestyle, these are the areas where male is neglecting himself. Socio-economic factor, he feels I am very powerful, I can tolerate pain, I need not to be insured. So many factors are there in male, and he feels that he should be seen as the strong person, and he suffers. And in all this scenario, empowerment of the elder is essential. Both these challenges cannot be met by the elders by themselves, nor by the government. Then what we have to do? We have to do the systemic, and what we are now targeting, that we were not thinking. You remember in your childhood that at the age where we used to say that old person is going. But now the WHO has also changed the definition, and you are young till at least till the age of 65. So this is the new definitions of young, and it was unthinkable that male is surviving beyond 100. This was the problem. So age-friendly pyramid we have to concentrate, and this is from age pyramid, friendly communities are needed. Age-friendly primary health clinics are needed, and age-friendly secondary, tertiary services, hospitals, and then age-friendly cities are needed. And after that, finally, age-friendly India we are targeting, and their male is to be cared for. So male gender and aging, this is the old home in one of the place, and you see what is happening. Is there any male? At this age, most of the men is disappearing from the society, and they are dying early. This leads to more burden, economic burden, because female is economically backward, and more GDP suffers, more economical burden on the country, and also widowhood, and lonely females, they get more socially deprived, and there is a lot of problem because male is dying early. And therefore, it is very important. You see on the right side of the cartoon, there are females. At every age, they are surviving at least 2 to 5 years more than male. And then when we concentrate on male health, there are, I have already told, back integration concept of the specialties, understanding why we need men's health as a dedicated specialty. Basic statistics, data is missing. If you see that stone, I am a urologist, kidney stone disease, do you know that what is the ratio? It is 3:1. Stones are more in male. Cancer, bladder cancer, some places 8:1. Kidney cancer, 3:1. So these statistics are missing. You are publishing your data, you can republish everything. Of your all the papers you have published, the male and female you see, and then you can take out the Indian data. The reports have been published of US, of Europe, of Australia, of Asia, and you will be surprised that UN10 has published Asian report, and their Indian data is missing. They have based on mostly Chinese and Korean data, the Asian report. So what we need is our own data, of Indian data, and what is important, and also models we have to design for practicing men's health in your own clinic, in your own institute. There are some institutes in Bihar and UP and also Bombay. They have dedicated timing for men's health clinic. They are men's health friendly institutes, and we have to work on hub and spoke model. Hub is the training center where primary, secondary and tertiary modules are taught, and then there are spokes who are getting benefited training of trainers, and also they start their specialties. And now in the new education policy which India has adopted, we have to start certain programs, the modules, the 4-month or 3 months even courses, and where this is important, that when you are starting the skill course like ECG course or dental technician course or other courses, this gender sensitive courses are also now introduced, and I'm happy to share with you. Baba Farid University has become the first university in the country and one of the very few in the world who has started dedicated men's health specialty and course, which is a recognized course, and now admissions are going on. So what services this specialty will offer is important. We'll discuss, and how to practice. the men's health, how we will handle them, and also limitation and challenges we will discuss. In the ancient times, men's health was supposed to be the indicator of society's health. You see, whether it is Ayurvedic or Chinese medicine, or there is no discussion about female health. It is only about men's health. And only, in fact, 200 years before, female was not allowed to discuss their health. Their books were not allowed, and after NGO movement also that all started. And female reproductive anatomy, Know Your Body, the book was first published only 200 years back. And it was not allowed before that females are allowed to discuss. It was only men's health which was giving the indicator of the society's health. And there is after that enlightenment and industrial revolution and inclusion of the women in the medical practice. And gradually what happened, that it became dominated by the female-centric programs. Now you try to recount your national health programs. Mostly they are on infectious disease or female or child. Is there any program for male health? There is no. I have told you so much morbidity for male, but there is no program, and the budget is also meager. And you will be surprised that it is not only in India, in US also this is happening. So what is the present situation? Our effort is to make health equitable. That male should also get the longevity equal to female, and whatever extra we have to do, that we have to do, and concept and definitions are: male is genetically weak. He is high risk roles, war, occupations, road traffic, accidents, everywhere male is exposed more. And substance abuse. You know that in Russia, because of substance abuse, in India the difference is 3 to 5 years between the life of span of male and female, but in Russia it is 12 years. So substance abuse, obesity and other factors, they cause early death of male. And social isolation, most of the vagabonds are male, and also street children are male. Herculean image male has formed for himself, but that is not the true picture. And there is lack of effort, I have discussed. So there has to be male-specific, social condition-specific, more morbid or common diseases in male are to be studied, and also behaviors, because psychologically it is very important. It's the mental health we talk about nowadays, and the male mental health is very important, because I told you that 3 times suicides are in male. Now what is happening? Why it is happening? One, genetically weak, and other things, risk-taking behavior, all that is there. But in female, what is happening? That in menarche or irregular periods are there, or you are advising pap smear, or you are advising need to look good, then for that female has to visit the doctor. Or so many things are, childbirth is there, and also menopause is there. So female gets so many opportunities to interact with the medical care. But what is happening in male? There is no occasion. And it is when male is not able to work, then only he goes. So you see that even the diagnosis and treatment and care is so much suffering, and we have to do something. And men's health is different, because when men's health comes to our mind, in almost 1 millennium years, it was thought that men's health is the only sexual health. And after that, and all your medications are directed towards that. And after that, a new urology subspecialty, andrology came. And even andrology is not men's health. We have to understand, men's health is orthopedics, men's health is ENT, men's health is oncology, men's health is psychiatry, everything. So the whole concept is wrong, and that is why back integration is there. And another important thing, it may scare you, that man is endangered species. I'm not joking. I'm not joking. I'll tell you the evidence, because ultimately, not immediately, but after 100 million years, men will disappear. Why? So you are laughing now, you see. That life expectancy, I have already, different races have different life expectancy. And evolution of Y chromosome we have to understand. 166 million years ago, Y chromosome in mammalian ancestor turned upside down. It turned upside down. And what happened? The X and Y, the gene swapping was not possible. And we started losing the genes on Y. And you know that today, in this evolution, Y carries mere 19 of the 800 genes it originally shared. So we are losing the genes. We are left with only 19 genes. And mostly they are disease-carrying genes. So you can see that how much disadvantages we are at that level. And if versions of this gene crop up on another chromosome, Y chromosome could be replaced. So it is not theory. I'll tell you the example in nature, what is happening. And males ultimately will become from XY to X0. Existing gender gap which is there is increasing, and this is 3,000 genes are there on X chromosome, and Y it is only 50. It is telomeres of X are long, they are the energy giving in the cells. So there are so many differences, and which are, if you realize, now what are the consequences? The consequences are, you see the third point in this, the male Japanese Ryukyu spine rat, the Y has been lost in that. And male rats are only there, and they carry the reproductive functions also, and after one particular age, they become capable of mating and reproduction. So this is happening, and ultimately it is going to happen that there will be only females on this planet, and there will be no males. So be careful. So other names, therefore, of Y chromosome are functional wasteland. Functional wasteland because only disease-carrying your sex identification genes are there, or others are disease-carrying genes. Their inheritance is there. And non-recumbing desert, another name given, and gene-poor chromosome. So now I think you are understanding that males are burdened with the natural genetic deficit. And genetic basis of survival, women are born with longer telomeres. People born with longer telomeres live longer. And cells that produce your immune system can function longer. And women have genes that allow them to mature in many selective ways, and genetic diversity is directly proportional. I'll also tell that women is shorter in height and male. Those races I have just shown in the slide, like they have tall people, they live less. I'll tell you, you are fond of your pets. The tall dogs, they live shorter. And the small dogs, they live longer. So these are uniform things, and which we have to observe, and also, and there are many species where after giving the female, it kills the male after mating. So there are so many things which are happening in the nature, and we have to understand when we are trying to understand our medicine for human race. And metabolism and lifespan is similarly meant. The bodybuilders, they burn their cells, and in female, the anemia, we say that it is bad, but the less iron in female is prolonging their life. I'm not saying severely anemic, but more the hemoglobin, the shorter is the cell life. And stem cells are exhausted at one stage. So these are all proven things, and we have to understand fetal survival. More male pregnancies are there, but they keep on aborting. And ultimately, stillbirths are also male more. And also after infancy, the newborn female is equal to, in immunity, 3-week-old male. Now you will understand why intracranial hemorrhages or pneumonias are more, and so many diseases are more in the newborn male. So this is important, and fetal survival I have already discussed, and therefore I think you have understood that there are lot of now literature available that males are endangered gender on the verge of extinction. I think now you will not laugh. So male is the weaker sex, we have understood since inception, and higher risk of preterm birth, and male births trends based on gestation is in this cartoon. You see that males are aborting more, male are dying more, infant mortality in male is more. So it is always happening, and fetal sex and preterm birth are male at greater risk. A lot of studies are there. Now gender aspects of the preterm birth, newborn male disadvantages, lot of literature is available now, and neonatal and infant outcome in boys and girls born very prematurely. There also female can be saved more than male, and females are therefore designed for survival. And sex-based differences in the infectious diseases I have already discussed. Even tuberculosis is more in male. All viral infections, COVID, even black fungus which you witness, more in male. Everything, infections are more in male, and cancers are more in male. These are very important facts, and this needs data analysis and also guidelines. And that is what Men's Health Society of India, where I am the president, we are doing, and we have now tied up with the Indian Medical Association, and there is a special cell created. I am chairing that cell also in the Indian Medical Association, and we are designing new curriculum with IMA also. So disease burden among boys, I will not go into that detail, prone to one by one, all the diseases I have in discussion already told you, but you see that even the reading delays, deafness, autism, ADHD, these are 3 to 4 times more in male. Blindness, seizure disorder, hyperactivity, Asperger syndrome is 10 times. So these are important facts which I wanted to share with you. Now, what is the difference in male and female? This is anatomical difference, this is physiological difference, or it is the ecosystem where physique and hormonal milieu that is interacting with the nature? Yes, that is the thing. What is happening, the structurally, the male and female structure, these blue structures are larger in the healthy male brain, and structure which are pinkish, they are larger in the healthy female brain. So anatomically difference is there. Then after that, functional difference is there. The anterior, posterior and visual cortex, all when we map the brain, male and female functions are different, physiological also. So what is happening? It is the hormone environment interactions, and male and females exhibit sex differences because of the same hormones are acting on the sexually dimorphic brain. Structurally, brain is different. So, reasons we have already discussed, that genetic stress, risk-taking, metabolic syndrome, and many unrecognized factors are there. Once it is developed at specialty, we will go into this, and this is the image just opposite to what is in your Herculean images there. This is the Vitruvian men, today's Vitruvian men. So you see that what is happening to men. And current status is that report I have told, American report is there, European report is there, Australian report is there. We need to organize ourselves, all the subspecialties in India, to create Indian report. and even in Asian report India is missing. The key reasons are that we have to maintain the gender ratio till the end. And what is the ratio? If 10 females are surviving beyond 100 years, only one male is surviving. So ratio is 1:10. This has to be reversed. No central program is there, I have discussed. Prevent creation of dependent population. Economic slowdown, it will cause, if males are dying early and females are remaining, there will be loss of economy and GDP. And you know that today is the wellness and sexual health business. How much is this? It is 20,000 crore business. And who is handling? Not the doctors. So it is very important that we are alert. We are the medical practitioners and we have to do something, because it is not only urology, andrology, sexual medicine, but it is cardiology, orthopedics, ENT and psychiatry, and you name any specialty. Men's health should be in your mind. And out of 20,000 crore business, only 500 to 600 crore is regulated. Rest is with the quacks and these all Jhola Chap doctors. So current organization is important, that the medical community is interacting, overlapping with the sexual medicine and wellness medicine also. And these are important sites which has to be there. Then comes that who is the doctor for men? 500 men were surveyed, 92% told that we don't know. 84% felt that men's health means sexual health. 76, someone to treat them. And then they thought that they need to be treated. 21% had already been to a quack. So 1/5 are already visiting. Some are not doing anything and others are visiting quacks. And it is incomplete cure. Missed opportunities are there where we can intervene for the better health, and emotional, economical setbacks are there. We have to now, what we have to do, paradigm shift is needed, and we have to lead the peaceful and fruitful life, and we have to see men differently. We have to see the problem differently, and also provide men-friendly facilities like screening opportunities, posters encouraging men's health, to talk, to discuss, and to genetic awareness is also important, and premarital pre-marriage examinations and other things, these checkups are, interventions are needed, otherwise men will not go to the doctor to get intervened. And men's health and sexual dysfunction, which is the common concept, that men's health is only sexual medicine, that is also not very much wrong, because I'll tell you that metabolic syndrome affects every organ and all the whole life, and it is more in the men. What is happening? That we say in our sexual medicine, penis is the barometer of sexual health. And what is happening? On the right side you see physical disability, diabetes, hypertension, CVT, everything. First ED will happen, erectile dysfunction, and then you will diagnose the disease. It is not true on the left side. It is only with the erectile dysfunction that it is the indicator, it is the surrogate marker that something wrong is happening and you need checkup. And that's why men's health clinics are needed. And your interrogation in your clinic, whether it is cardiology clinic, whether it is urology clinic, everywhere some basic questions should be asked. And this is important because heart disease, the coronary, your problem, 2 years back ED will start. And from for your this stroke, 10 years before ED will start. So these are very closely linked and studied. So now I come to what we should do. Lifestyle, we have certain things we say it is Ayurvedic, it is homeopathy, it is allopathy, modern medicine,
What is lifestyle changes? We have to concentrate in men. These are yoga and other things. This is what the modern medicine says. After that, nutraceuticals. And Indian knowledge system, now Government of India has now mentioned that we should integrate Indian knowledge system, and therefore there should be integrated medicine, which is integration, and also I'll add that there should be BET integration and men's health, and all these are in the non-traditional integrated medicine education, which has to be there in the medical institutions, and then comes medications, your true medications, which are now has to be evidence-based. Even Ayurveda is going for evidence-based now. And we have the new Gazette notifications after 2019, and all it is the opportunity open that you make your product evidence-based and clinical trials are available. And then if nothing is happening, surgery, surgical, lot many surgeons are sitting here, that ultimately when nothing happens, then most of the diseases you offer surgery, even kidney fail, then you offer kidney transplant or liver transplant. So the men's health we have understood, they are prone for risk taking. If you have your son and daughter, if difficult work is there, you tell to your daughter, you leave it, he will do it. So this is the basic risk taking everywhere, and unable to care for their health, and highly indulgent, master of all trade, they think we can do everything, especially, and they feel they are descendants of Hercules and tamers of wild horses. So that is not the picture. And they are too busy for health. They are not caring. Continuum is there. There are so many comorbidities which are to be studied, which can be endothelial dysfunction and affecting various organs in the comorbidity. Not only that, after COVID we have understood more that it is not aging, it is not only comorbidity, it is not only endothelial dysfunction. Most of the diseases are inflammatory diseases. Even obesity is inflammatory, diabetes is cancer is inflammatory disease. So we have to understand that these all are overlapping, and in COVID, whosoever suffered from these diseases, he suffered more and died more. So comorbidities are important, endothelial dysfunction and inflammation, it is more in male. Men's health care models we have to discuss, and you have to become the men's health expert. Maybe you are orthopedician, in your practice you dedicate some time for men's health. And you are as clinical lead, you can refer, or you are the part of the men's health care team. And there is standalone situations also. Some standalone men's health clinics are coming up very fast. In Delhi itself now, I am aware of about 20 people who are only, they have written that men's health clinic. And these are coming, and this is the future, and many people have the very, very profitable models in the private practice. And institutes also, Paras Hospital of Patna, they are earning like anything in men's health. They have the entry, anybody is entering the institution, they segregate that if you are male, fill this form. And after that, many people are diagnosed. We had the prostate disease awareness drive in India, and pilot project was there, and we diagnosed many men's health diseases as well as the prostate cancer in these camps, which people were not aware. So special drives are needed, and we have to initiate the strategies not only in the old age, but it is a continuum through ages. And we have to entry checkup. I was telling now we have to entrance, because female gets more exposure to medical interventions. Now we have to create interventions for male, and entry checkups at the time of admissions, maybe in the school, before marriage. The checkup is executive checkups, and I was the person who designed for all the administrative services, the paper, the examination schedule, and in that I introduced certain men's health friendly parameters also. You are all aware, you must be doing the executive checkup of the officers. The whole thing was started in 2007, and Kim was, I think, secretary at that time of USI, and I was made the convener, national convener, and we started the drive. And then parenthood, we have to be aware and make health an important performance indicator. Make health accessibility and friendly, accessible and friendly, and special opportunities I have discussed now, that pre-marital checkups should be there, basic men's health checkups should be there, executive health checkups should be there, geriatric wellness checkups should be there, and pre-recruitment checkups should be there. Is there any need of setting up men's health guidelines? We have created guidelines. We are now on version 3. We have added certain infection-related guidelines recently, especially after COVID. And why we need men's health, we have understood. Chronic damage to the longevity of man is happening. Men are not capable of self-care. And men are too self-reliant, and men have no social support. Men are taking all the risks. So these are the salient points I have already discussed, and we have to think beyond health, and certain holistic therapy we have to think, and especially India. We have to think in the lines of Indian knowledge system, which is integrated in the new education policies. We have now designed in the health guidelines. These are available on website, that recommended checkups when they should be done, a checklist that what all is to be focused, and also the holistic management, in which direction we should go if we want to live at least at par with our female gender counterpart. And also we have to morph our practice. We have to morph our practice, which has to, we have to understand first men's health, then equip your clinic. It is not very costly. Very small equipment and gadgets are needed, and reform your facility. Keep some education material there for the waiting room, and also associate with the social cause. And urologists started this drive, but it is for everybody. We started because it was male-specific parts were there, like prostate or infertility and sexual dysfunction, but it is for everybody. And all the specialties are to be integrated, back integrated, and therefore it is not that only urologist or cardiologist or psychiatrist has to practice. Everybody has to practice. And how should expert integrate with the primary healthcare provider? This is the men's health expert is sitting in the center, and sending the patient to the respective specialty, and that specialist is supposed to send the patient back. So this is the center. This is a family physician or family medicine centric model has to be there for the men's health, and also the basic specialty. We go to specialty and super specialty, and then ultimately when we talk about men's health, all the specialists are back integrated. Training modules we have designed, they are available, and we are giving 3 levels of training, and men's health expert is with module 1. Any specialty can take this. Then those who are specialists, they go for module 2. And those who want to become men's health expert or exclusive practice of only men's health, they go to module 3. This is the tertiary level. And these are the guidelines which we have already published, available. I'll not go into the detail. And deputy team in your institution, define roles like a tumor board. You have to do the men's health multi-specialty board, detailed evaluation, distribute the patient, and discuss the solution, deliver holistically. You start your practice with the dedicated team and with the dedicated area in OPD. It is not very big area is required, and allot adequate time for the consultation, and number of revisits needed are only 1 to 2. and you will diagnose the main problems in the men, and patient planning is important. Then you need what facilities when you are developing the new facilities. Couple of rooms licensed with the experts. You should be able to license with all the experts. And also sample collection facility and basic assessment auditorium. What are they? Glucose monitoring, not difficult. ECG, not difficult. Uroflowmetry, not difficult. And instruments for assessment of vitals. So these are the basic gadgets which are required, otherwise also. And space for display and tie up with the resident welfare associations. So patient workflow is registration to evaluation to referral to follow-up. So this is what at all the levels you have to do. And this is the ideal men's health clinic, which we are helping designing all over India. Anybody who wants to design, we are, our effort from IMA also now is to help designing and what should be the flow inside that facility and at the time of revisit. These are the various things which are to, at one end patient enter and on the other end patient comes out. So opportunity is waiting, it is to be taken. Men's health is new in India, only concentrated upon globally 2 to 3 decades. Only few centers are there, very few trained experts are there. Most of the funds, they are unregulated, and ample avenues for training, diagnostic as well as therapeutic opportunities are there. And this is a totally disorganized space. We have to now organize this space. We have to concentrate and let's come together to deliver a continuum of care that men deserve. Thank you. I think for some of you it is new, and I chose this topic because this is the month of November. It is called Movember also. Thank you.
Thank you so much, sir, for this amazing talk. I think all of us have learned a lot from sir's talk today. Now, I request Dr. William Bhatti, Dr. Jairaj Pandian, Dr. Alan Joseph, Dr. Karamveer Goyal, Dr. Navneet Kumar Chaudhary, Dr. Nitin Agarwal, Dr. Maninderjeet, Dr. Tarun Satija to please come forward and felicitate Dr. Rajiv Sood with shawl and memento. Let's appreciate all the dignitaries on the stage with a huge round of applause.
A round of applause, especially from the ladies after glorification of immense by our worthy speaker.
We also have a special event. I request the dignitaries to please stay where they are. So we have a special event that is the release of a book on urinary tract infections. I request Mr. Bipin Gupta, Secretary of DMC, to please come forward and join the dignitaries and kindly release the book. I also invite Dr. Bishop Mohan to please join the dignitaries on the stage and release the book on urinary tract infections. The author of this book is Dr. Swati Jain. I request ma'am to please come forward for release of this book. Dr. Swati Jain. A huge round of applause. Thank you so much. I think we all should read this book. It's a very common thing that we need to treat on an everyday basis. I request Dr. Tarun Satija, Treasurer of Dr. L.H. Lobo Memorial Trust, to please come forward and deliver the vote of thanks.
Thank you. It's my pleasure to stand before you and deliver the vote of thanks for this oration. First of all, like to thank CMC administration for encouraging us, especially Dr. Bhatti, Dr. Jairaj, and they've been always with us. I am grateful to PMC member, especially Dr. Karamveer, my friend, who has been instrumental in giving us 4 hours of credit hours. And Dr. Rajiv Sood, it has been a wonderful oration, and thank you for coming here. But it was very scary to know we'll be extinct soon. And I didn't know we were at such disadvantages. Only thing I wish, and I'm sure many men also wish, their wives had been here so that they can treat us better, because considering the disadvantages we have. Thank you, sir, for enlightening us. We have a lot number of speakers and chairpersons from all over the country. They'll be enriching us with their knowledge. Thank you, sirs and ma'am. Today is a special day for Dr. Lobo Memorial Trust because we've just released a booklet for education of general masses. This would not have been possible had it not been the coordination of 2 great institutions of this town, CMC and DMC. They agreed to our request and made the booklet, and we have released it today in CMC. So thank you, administrators, especially Dr. Bhatti, Dr. Jairaj, and Mr. Bipin. It's been an honor to have you here, sir. Dr. Bipin was busy, but he accepted the invitation of the trust to be here. Thank you, sir. Well, the surgery and urology department have done an excellent job, and thanks to Dr. Nitin and his team. Thank you, Dr. Nitin, for making this possible. I see a lot of dignitaries, colleagues, friends in this auditorium. Thank you all for coming here. And audience also. This oration would not have been a success if you had not been here. Well, the most important thing, as I remember when I was a student, was the tea break. So we have it now. So I request you all to join us there. Thank you.
The tea break is going to be for about 20 minutes. I request you all to be back by 11:35. The breakfast has been arranged in lawns near Blood Bank. Thank you so much. Welcome back. We are beginning with our CME now. We'll be starting with our guest lectures. I invite the chairpersons for the lecture, Dr. Arvind Goyal, Dr. Rajesh Khosla, Dr. Ankush Jairath, Dr. Angad Jot Singh, Dr. Anil Luthar, Dr. Neeraj Goyal to please come on the stage and chair this session. The lecture is by Dr. Katumala Francis Sridhar. He's a consultant urologist, andrologist, and kidney transplant surgeon at KIMS Hospital, Hyderabad. He has 2 decades of experience in the field and has several prestigious awards to his name, including Gold Medal for Best Outgoing Urology Resident from CMC Vellore and Professor A. Rajashekharan Gold Medal from Dr. MGR University for Urology. He is an esteemed member of the Medical Council of India, South Zone Urological Society of India, American Urological Association, and Society of Genitourinary Surgeons. I invite Dr. Francis Sridhar to please come forward and deliver his talk on complicated urinary tract infections.
Good afternoon, everyone. It's 12. Sorry for barging in. I was supposed to be talking second, but I have asked Dr. Uma to stay back, and thanks, Dr. Uma. And I'm so honored to stand here today and speak in Dr. Lobo Memorial Oration. And I've been sitting there in those chairs for so many years in so many occasions, and even in previous Dr. Lobo Orations, I was sitting there as a medical student. All this started in 1993 when I joined CMC here as a medical student. And a boy from South India was exploring Punjab then. I finished my MBBS and MS General Surgery from here. And I moved on to Vellore to do my MCH urology. That's Dr. Ganesh, Dr. Nitin, Dr. Nainan, and Dr. Anthony. They are the doyens in urology during that time, and even now. And after I finished from there, I came back to CMC Ludhiana and joined the department with the man himself, Dr. Kim Maman. Looking at this picture, you know who ruled that area at that time. We had a good time in the department, and not just fun, but even at work. It was good, and when you're working with Dr. Kim Maman, it's always great in the theater. So now my topic, after that I've moved to Hyderabad. I'm working in KIMS Hospital, Hyderabad, and anybody who is coming to Hyderabad, please get in touch. We'll have a good time there. Now, this picture was taken in 1996 when I was elected the president of Students' Council. This is the same auditorium, and the picture was taken here 30 years back. And now again, I'm standing here talking some urology. Now my topic today is complicated urinary tract infections. I would have preferred a surgical topic, but complicated urinary tract infection is very important. And it's very important to diagnose this early, because the clinical scenario will not be it's not going to be the same as a uncomplicated urinary tract infection. You will need a very detailed workup to identify this entity. You have a higher risk of treatment failure, longer course of treatment, and different regimes of antibiotics which are needed. So one will always find a host defense factor which has failed to prevent the infection, and the risk factors which are worsening the sepsis. That's what it causes the higher mortality and morbidity and treatment failures in complicated urinary tract infections. Now defining this is very difficult because we don't have a homogeneous group. Everything is different. The clinical presentation, each patient will be presenting in a different situation. The mild cystitis to severe urosepsis, the risk factors, the severity of the risk factors, and the bacterial composition, like different strains, the virulence factors will be different, and even at the molecular level, they'll be different. So it's all a heterogeneous group. So that's why it will be very difficult to have a homogeneous group. But still, when you want to define it, you will want to assess all the factors, the clinical factors, to identify which organ it is coming from, whether it is from the urethra, the bladder, or the kidneys, or what grade it is presenting at. Is it just a low-level cystitis, or the patient is in urosepsis, or what are the host risk factors, the pathogen factors? All this needs to be taken care of to define complicated urinary tract infection. Now, there's a very big list of which can be labeled as a complicated urinary tract infection. Now, when they occur in men, pregnant women, renal transplant patients, immuno-compromised patients, patients with impaired renal function, all these are the list of complicated urinary tract infection. And when they happen as a result of urinary tract abnormalities, like if they have any congenital abnormalities or any pathologies like stones which is blocking the system, obstruction, fistula, and when they occur due to atypical organisms, not the routine E. coli or whatever, but atypical organisms, and if they occur after instrumentation, all this will be labeled as complicated urinary tract infection. Now, the main culprit is usually the perineal and the rectal flora, which colonize the urinary tract. Now, E. coli, Klebsiella, Pseudomonas, Enterococcus, these are the most common organisms which can be seen. Candida is seen in specific situations like patients on catheter or diabetics. So, for uncomplicated urinary tract infection, the most common organism is E. coli. But when it comes to the complicated urinary tract infection, whether it is cystitis or pyelonephritis or urosepsis, other pathogens are more common than E. coli. So, the broad spectrum of bacteria which causes a higher risk of multi-drug resistance and clinical complications, and this needs a broad spectrum antibiotic for a longer term. Now, nearly 2% of all hospitalizations, annual hospitalizations, they are because of this complicated urinary tract infection. And all the bacteremias, 20% of them will be, the origin will be from the urinary tract. And in this group, 10% will have mortality. Now, if you talk about specific risk factors, like if you take a diabetic woman, there are 14% chances of them developing a complicated urinary tract infection. And if patients who are on Foley's catheter, now there is a 10% daily risk of bacteria, and there is 25% risk of this progressing to complicated urinary tract infection. Asymptomatic bacteria, not all of them will require treatment, but that is more seen in elderly women. And nearly 10% of all urological inpatients will have complicated urinary tract infection. Renal transplant patients, immuno-compromised, obviously, 25% of them will have complicated urinary tract infection in the first year. So that's why they'll need prophylactic antibiotics. Now, this pathophysiology, it's always the virulence of the bacteria which breaks down the host immune system causing, and then they survive within the body. Now, the main defense mechanism in the host, it is the innate immune response. Now, what happens is when this bacteria gets stuck to the urothelium, now this toll-like receptors are activated, and then this cytokines, interleukins are released. These neutrophils go and get attached to those receptors, then causing phagocytosis, killing those bacteria there. But genetic polymorphism in the bacteria, this causes this dysfunction of receptors in the innate immune system and increases the susceptibility to all these different sorts of UTIs. Now, bacterial motility, biofilm formation, production of toxins, these are the virulence factors in the bacteria which sort of make them serious and which enhance the microorganismal survival and thereby the potential of uropathogens to cause the disease in the host. Now, biofilms, this is the microorganisms, they are encapsulated in a slimy layer sort of a thing which gets stuck to which is formed by the polymeric matrix. And they stuck to either the tissues inside or the foreign bodies like stones and Foley's catheter. And these multiply inside, the bacteria multiply inside the biofilms. Now, the antibiotics cannot get into these things. These things make these organisms very virulent. Now, this is the same thing which I said in detail. Now, this diagnostic workup for the complicated UTI, we've been doing this for years. First thing is, if you are suspecting a complicated UTI, you don't wait for the results or the reports to come. You just start off your treatment. And obviously, a very good urine report, urine sample is required. That's the key. Now, urine analysis, urine culture, blood culture, and mainly the imaging, which will sort of help us to diagnose. This is a differential diagnosis for complicated urinary tract infection. Now, the management. Now, parenteral broad spectrum IV antibiotics, this is the mainstay. Now, we need to start these antibiotics before the cultures come, and obviously, you need to look at the local bacterial resistance patterns, and microbiologists will be able to help us with that. And if the patient is presenting in sepsis or in urosepsis or, when they are sick in shock, resuscitation is the main thing. And even though you start your broad spectrum antibiotics, when the culture reports are ready, you de-escalate the antibiotics to a narrow spectrum antibiotics. Surgical interventions are needed, and the response will start within 48 to 72 hours. But it's very important to make sure that your treatment is not failing, and inappropriate antibiotic selection, polymicrobial infections, atypical infections, anatomical abnormalities, any complications, or if you have missed anything, any pathology inside which requires surgeries, all these things will lead to a failure of the treatment. Proper antibiotic selection, appropriate dosage, correct duration of therapy, and surgical procedures whenever we need, that is the key for treatment. Now there's something called as bladder installations. People keep talking about antibiotics, putting it in the bladder to make sure you treat the complicated urinary tract infection. It's a conflicting evidence. Mostly, even if it is of any use, it is used in renal failure patients where the urine output is less, but otherwise no. Prophylactic antibiotics should not be given to all, very limited use, but if by chance you need to give prophylactic antibiotics, it is nitrofurantoin 50 milligrams once in the night for a long term. Cranberry supplements, yes, conflicting evidence, not very sure about that. Now there are these newer antibiotics agents which are coming for this multi-drug resistant infections. Now because all these bacteria are becoming resistant to the antibiotics which we are using now, we are looking at the older antimicrobials or the newer drugs which are coming up and with combinations. The most commonly which we use now is third generation cephalosporin ceftazidime with beta-lactamase inhibitors avibactam. Now this plazomicin is one of the newer aminoglycosides which are used for the carbapenem resistant bacteria as well. Now there are different high risk groups. Suppose COTI is catheter associated urinary tract infection. Now they'll have a Foley's catheter inside. That's a high risk group. Nearly 15 to 20% of all hospitalized patients will need a catheter. Out of that, 20 to 50% are unnecessary catheters. So as much as possible, avoid catheter, and if it's really needed, make sure you follow all the guidelines. And 70% of COTI are preventable. Neurogenic bladders, the bladder is not functioning well. It's better to the patients to be kept on clean intermittent catheterization or a SPC compared to a Foley's catheter. And asymptomatic bacteria is usually seen in these neurogenic bladders which don't need treatment. But asymptomatic bacteria which is seen in pregnancy will need treatment, because if there is a untreated UTI in women, there are high chances of low birth weight, babies, prematurity, preeclampsia and all. Now renal failure, there are many reasons why renal failure will develop a complicated urinary tract infection. Reduced urinary volume, uremic immunosuppression, urinary excretion of antibiotics will be less. So dose adjusted antibiotics will help here. And here, that's what I was saying, antibiotic bladder installation may be of some help in oliguric renal failure patients. Renal transplant, post-renal transplant, they are immuno-compromised. 25% of these people will develop a complicated urinary tract infection in the first year. So that is why the prophylactic antibiotics, but if the patient is sick and there are severe symptoms, then you will need a parenteral IV antibiotics. Emphysematous pyelonephritis is a very bad disease to have. It is a necrotizing infection of the kidney with gas within the kidney, in the PCS, perinephric areas. Emergency drainage is needed, whether it is a PCN or a PCD or a stenting. And poor prognostic factors. Suppose if the patient is presented in shock or confusion, azotemia, thrombocytopenia, hyponatremia, these are those risk factors where the prognosis will be poor. Xanthogranulomatous pyelonephritis, it mimics RCC except for these xanthoma cells, and it's the same thing. It's a very bad disease to have, and antibiotics, drainage, and if it's a non-functioning kidney, then nephrectomy. Pyelonephritis is one of those urological emergencies where the kidney is completely obstructed, and the obstructed kidney with lots of pus in it, fever with chills and flank pain and sepsis. Those are the symptoms. Emergency drainage, whether it is stenting or PCN, and later on you assess the function of the kidney, and then you take a call whether nephrectomy is needed. Now these newer diagnostic ones where there are computer programs with artificial intelligence algorithms and newer biomarkers, this will speed up the diagnosis and give us an information about the accuracy of the antibiotics. The new catheter materials for less biofilm formations, bacterial growth interference agents, anti-infective vaccinations, these are the newer things which are in the pipeline. New classes of antibiotics which we have talked earlier. Now, bacteriophages, these are viruses which sort of destroy the uropathogens. These are also in the study thing. Now the main thing is teamwork. Teamwork is always for the betterment of the patient. Now urologists, nephrologists, intensivists, nurses, everybody put together, and all of them should be concentrating on patient education, infection prevention, and monitoring for treatment response. I'm sorry for being so fast. It's time for my flight. That's why. Thank you so much for the attention.
Thank you, Dr. Francis, for a very quick, very detailed, and excellent presentation. I think you made it very simple, this complicated UTI presentation, and I think most of the students will also understand. And thank you very much. And most of the time in hospitals, what we are dealing with the multi-drug resistant organisms. And we'll end up using multiple drugs, very high end of antibiotics in combination therapy. So that is the problem we are facing nowadays in like ICUs, like you said, catheter-related infections, you know. And many times we try to avoid catheters, but in patients where we can't, so the beta-lactams, that ring antibiotic, that organisms, E. coli and others. So that is the problem we are facing, and we'll end up using very high end of antibiotics. That is a challenge in the tertiary care centers and in many hospitals as well. Once again, thank you very much. And you are not very fast. We could understand everything. And thank you for your flight and everything.
The main thing here, sir, is the first step of catheterization. When I was here, I used to take classes for catheterization. You need to make sure, follow all the guidelines, make it as aseptic as possible. And the first infection sort of goes from there. And then is the catheter care, which are important. And all these patients on catheters, if they have asymptomatic bacteria, if they're not symptomatic, you don't need any treatment for that. But yes, catheter care and it's more important.
Yeah, I think that's very, very important. In our practice also, we give really very importance. I still ask my all PG students to, where is the catheterization set? Nowadays in theater I see they start putting catheter without even proper draping the patient, you know. They do it very quickly. So again and again we make sure proper draping before you catheterize, what all areas you are touching before you put your catheter, and no touch technique. So we are also very, very careful. As you said very rightly, prevent infections.
Yes.
Thank you. I'll give to Dr. Neeraj.
Thank you, Dr. Francis. Very nice presentation. Any question from audience? I think there is no question. So let's move on to the another presenter.
There are two questions for the audiences. There are prizes also for them, just to kind of check whether you guys are paying attention and just to drive home some important points. The first question, it's open to all the audience. Dr. Francis referred to a certain niche where the bacteria settle down in patients who are catheterized or have foreign bodies in them. What is that word which tells that niche? Where do they settle down? He talked about a slimy layer. What is it? What? Okay, so it was an open question, I suppose. Can you just raise your hand and one person answer? We can't split the prizes to everybody, sorry. Okay, right. Okay, for the benefit of us, I'll ask one more question. So, can any one of you, just raise your hand and answer one at a time. Can any one of you name one high risk for developing a complicated pyelonephritis? Any one of you, please raise your hand. One risk factor for developing a complicated pyelonephritis. Somebody's here. That is one of the preventions for reducing the thing, but patient-wise, what are the 2-3 patients where you will say this guy is, even though if he's a normal person outside in the public, he's got a higher risk of developing a complicated pyelonephritis? Any one risk factor? Somebody else? One person at a time, please. Otherwise, no prizes. Sorry.
So diabetics.
Yes, correct. Uncontrolled diabetics. Is Dr. Swati part of the prize-getting team or conflict of interest? Okay. The second question is next question, just for the students specifically. What is the phrase which he used when you advise a patient to collect a urine sample? There was 2-3 words in it. Which is something you need to tell the patient when you're collecting a urine sample. One person, please. Yeah, you.
It was mid-flow sample, like fresh.
No, I want that correct one because that is something you need to take back home. Okay. One more word in it, midstream, correct? Clean catch urine sample, okay? What is midstream? So you tell the patient when he passes urine, not the first few seconds, into the flow, and then clean catches. You need to wash the glands, retract the prepuce, wash the glands with water, or spread the labia, wash the area, and then catch that. As midstream clean catch urine sample. The prize, you will get the prize. Thank you. Right.
I'd like to request the winner to please come forward and collect your prize from one of our chairpersons. Dr. Neeraj Goyal, would you please present them with the gift? Sir, please come forward, please. Yeah. Let's give him a huge round of applause. Yeah. Thank you. Now, I request Dr. Nitin Agarwal to felicitate our guest speaker, Dr. Katumalla Francis Sridhar. Sir, please come forward. I request Ms. Sharon to please hand over the token of appreciation to them. Now I request Dr. Nitin to felicitate our chairpersons, Dr. Anil Luthar and Dr. Neeraj Goyal. Next, we would like to welcome Dr. Ashima Taneja, Head of the Department of Obstetrics and Gynecology in DMC. And I request Dr. Kim Maman to please come forward and felicitate her with a token of appreciation. Thank you, sir. Thank you, ma'am.
Next, I invite Dr. Ashish Jindal and Dr. Ashima Taneja to please come on stage and share this session. And I invite Dr. Umakant Dutt, Head of Department Urology, AIMS Bilaspur, to please come forward and deliver his talk on uncomplicated UTI.
This one, huh? Good afternoon to everyone. It is always very overwhelming and nostalgic to come back in CMC. We work here for more than 3 years along with Partho. I would like to thank organizing team, director and Dr. Nitin Agarwal for inviting me on a talk. The talk is uncomplicated urine tract infection. The talk should have come first, but because of some change in the order, I will be presenting this after the complicated. So, uncomplicated urinary tract infection. In the morning, we have very good oration on men's health, and Professor Sood presented the talk. It was very enlightenment to us, and sir told that men are suffering more. But what talk I am going to give is, in this, the uncomplicated urinary tract infections, females have more incidence of infection. So objective of my talk will be the patient screening for the symptom risk factor, their relevant medical history, and after that, select the appropriate diagnostic test for the confirmation of UTI. After the diagnostic test, implement the evidence-based treatment protocol, and once the treatment protocol are implemented, collaborate with interprofessional team for ensuring comprehensive care for uncomplicated urinary tract infection. So introduction, when we say uncomplicated, the word itself say there's no complication. So uncomplicated urinary infections, they are the bacterial infection when they involve the urinary bladder and associated structure like urethra. And uncomplicated urinary tract infection, there won't be any structural or functional abnormality in the patient. There won't be any comorbidities like diabetes, immuno-compromised state, or any history of urological surgery or any pregnancy. And this uncomplicated urinary tract infection, they are also called as cystitis. Coming to epidemiology, so these type of UTIs, they are 4 times more common in females. And around 50% of the female, they will develop at least one episode of UTI during their lifetime. So that's what I told, that this is the infection which is more common in female. And about 10% of women, they develop a UTI yearly. And around 30% of the women, they will get treatment before the age of 25 years. And the common age of uncomplicated urinary tract infection is around 16 to 14 years of age. 16 to 40. Coming to etiopathogenesis of uncomplicated urinary tract infection. So these are the bacteria which are normally infect. They are entericoliform. So they start their journey from the perineum and rectum to the periurethral area. So that is called retrograde ascending route. And when these bacteria, they reach into the bladder, there will be bladder mucosal layer. They will infect that layer, and that cause cystitis. So you must have seen many times the ultrasound reports come to you as a clinician that will be showing cystitis. So these are the infection that is normally the uncomplicated urinary infection. So the uterine bladder mucosal involvement, that is cystitis. And common risk factors are there, multiple risk factors are there, like short urethra in females or sexual intercourse. So these are the things which promote the passage of bacteria into the urethra. And this is the slide also showing colonization, then there will be uroepithelial penetration. So once the penetration are there in the mucosa, it causes cystitis. So as I told, these are the bacteria, enteric coliform bacteria. So typically inhabitant of periurethral area and vaginal enteritis. And most common of these bacteria are E. coli. So 70 to 90% of UTIs are caused by E. coli. But in young females, that is below 30, around 10% of the women, they have 10 to 20% by Staphylococcus staphylococcus. And other bacteria which are normally found is Klebsiella, Proteus, and Enterovector. In uncomplicated urinary tract infection, blood-borne infection are very rare. So once the bacteria reach into the bladder and they infect the urothelial, there are some factors which have inhibition effect on the bacteria. Like urine is normally antimicrobial. There's some factor like unfavorable factor for the bacterial growth, such as urine pH. That is normally the urine pH is acidic. High urea level, hyperosmolarity, and presence of some organic acid, proteins, Tam-horsfol-glycoprotein, which are all inhibitory for the bacterial growth. And frequent urination or high urine volume, they are also an inhibitory effect on the bacterial growth. Premenopause ladies, they have vaginal pH, that is acidic pH because of coronary diphtheria and lactobacillus. So that is also have inhibitory effect on the bacterial growth. There are few factors that is also produced by the urothelial, like interleukin factors, like interleukin 1, 6, and 8, which also reduce the bacterial growth. But same time, one side is the inhibitory effect of the bladder mucosa, and second opposite side is bacteria, which normally want to grow inside. So bacteria also cause some breakdown in the defense mechanism. They break down the urea into alkaline ammonia, which increase the urine pH. So once the urine pH is increased, chances of infection will be high. So this is the European guideline for 2024, where the UTIs, they are divided into uncomplicated UTI and complicated. In uncomplicated UTI, you have cystitis, you have uncomplicated pyelonephritis, and recurrent urinary tract infections. And these are the low risk category. In complicated, that's already discussed by Dr. Francis. So risk factor, as I told few of them previously, that short female urethra and proximity of urethra to the anus. Behavioral factors are like sexual activity, especially the new partners, use of spermicides. So spermicide, they contain some component nano-oxynol, which change the pH of vagina from acidic to alkaline. So chances of bacterial growth will be very high. Then history of some UTI during the childhood, then history of UTI in the mother, and hormonal risk factor like menopause, because at that time loss of estrogen will be there, and that reduce the lactobacillus concentration in the vagina. So these menopausal lady will be having more chance of UTI. So once the patient present to you, then we have comes with a history and clinical feature. So most of time the uncomplicated urinary tract infection, they present with symptom like urgency, frequency, suprapubic discomfort. They may have dysuria. They may have sometime 5 to 10% hematuria and hesitancy. Odoriferous or cloudy urine may be present. So these are the symptoms that you have to elicit from the patient. Then you may have to take other history like information on the prior antibiotic use, because most of the time the patient present to you, they have taken over-the-counter drugs. Have they taken any antibiotic from the over-the-counter? And same time you have to ask any previous history of UTI. So this is the important history aspect. Then suprapubic tenderness, that is very rare in uncomplicated urinary tract infection. It's hardly present in 10 to 20% of the patient. Physical examination in uncomplicated urinary tract infection is typically negative. So when we have to diagnose an uncomplicated urinary tract infection, that it depends on the symptoms, sign, and other thing is urine analysis. And these are the diagnostic set for the uncompleted symptom, sign, and urine analysis. If you want to confirm the things, then you can get the urine culture. But for uncomplicated urinary tract infection, you don't have to go for the urine culture. Suppose patient has bacteria or pyorrhea, and if you get a urine analysis, there is a bacteria present or WBC present, but patient doesn't have symptom, then that doesn't constitute the UTI. So coming to evaluation. Evaluation, at previously also discussed, what is the sample? Sample is midstream clean catch. I still remember when I joined in CMC, I used to sit with Dr. Partho, and he always say one thing, midstream clean catch, midstream clean catch. And that is now in my permanent memory, that it is midstream clean catch. I am working in a public sector hospital. There are around 100 patients in OPD. So it's very difficult sometimes to say to every patient midstream. So I normally use my other health worker to just saying for the midstream clean catch. So this sample should be collected, and the sample should be sent to the lab immediately, or it should be refrigerated. So diagnosis of UTI, it again depends upon the clinical history and urine analysis. And proper collection of urine sample is very important. Okay. So this is the diagram where the above one showing the woman and the lower down is the man. So collection of sample is very important. They have to clean their private area, then they have to wipe from front to back. Then once the little bit of urine has been done, that is around 10 to 20 ml of, after that they have to collect the sample. In case of men, if the man is circumcision is done, then they don't have to do anything, just they can clean the area and then send the sample midstream. But if there is no circumcision done, then they have to retract the prepuce. After that, they wash the area and with soap or clean water, and then send the midstream sample. There are other things apart from the urine analysis, that is a dipstick test. So dipstick test, they are the more convenient, but they are less sensitive, and they can be done at the clinic or in the bedside also. The most things that can be picked by the dipstick test is like pH, nitrites, leukocyte esterase, and blood. So suppose a patient presents with a symptom of UTI, but there's a negative dipstick, it does not rule out the UTI. So, but if there's a positive finding, suppose patient has symptom and dipstick comes positive, this means it suggests a diagnosis of urinary tract infection. And most accurate test in dipstick test is nitrite test, because they are the important, they detect the bacteria. So leukocyte esterase test, they identify the WBC in the urine. So if we say that out of these three, the hematuria, WBC, and bacteria, the most precise one is the detection of bacteria in the dipstick test. Role of urine culture and imaging. In uncomplicated urinary tract infection, the urine culture is not required routinely, but it will be recommended because of increasing antibiotic resistance pattern in the community, or sometimes it may differentiate between the recurrent and relapsing infection. For the classical urine culture, the growth should be 10⁵, that is 1 lakh colony-forming unit per ml of urine. Coming to cystoscopy or some imaging study like ultrasound, it is generally not recommended in uncomplicated urinary tract infection. Coming to management. So normally uncomplicated urinary tract infection, they resolve by itself in 20 to 30% of the patient. Aim of therapy is to prevent the infection from spreading to kidney or progressing to upper tract and causing acute renal failure. So what is the management of uncomplicated urinary infection? The single dose of fosfomycin is a drug of choice. 3 grams single dose, 1 day therapy. That is more than sufficient in female. Other drugs like nitrofurantoin, it can be like 50 to 100 milligram or 100 milligram twice a daily for 5 days. In men, the drug of choice is, because normally in men we say that it is always complicated urinary tract infection. So Septron, the best is trimethoprim, sulfamethoxazole, that is double strength dose, 7 days. Coming to uncomplicated pyelonephritis. These infections normally happen in case of the non-pregnant and premenopausal women. There won't be any abnormalities structurally or functionally. Structurally, like there is no obstruction. Functionally, there won't be any bladder emptying disorder. So patient present with a fever, chills, flank pain, nausea, vomiting, and there will be tenderness at the costovertebral angle with or without symptom of cystitis. So you may have seen sometime the patient comes with a cystitis symptom, this urgency, frequency, dysuria, but they may say that I have some heaviness in my flank region. So this is the classical scenario of uncomplicated pyelonephritis. So management of uncomplicated pyelonephritis, the empirical oral therapy is ciprofloxacin, the fluoroquinolones, that is 500 milligram twice daily for 7 days. Other drugs like trimethoprim, sulfamethoxazole, or some spalocefurin. So this is again uncomplicated pyelonephritis, but parenteral therapy. So again, first line treatment is ciprofloxacin, that is around 400 milligram twice daily, but course of action is 7 days. Coming to recurrent urinary tract infection. So recurrent urinary infections, the frequency is around 3 years, 3 UTI per year or 6 UTI in last 6 months, and this can be caused because of persistence of bacteria or reinfection. The reinfection are more common for the recurrent urinary tract infection. Persistence is because of obstruction. So most of the time when there is a persistence of infection, it is because of some obstruction. It may be some stone, it may be some other strictures that should be managed by surgically. And women with reinfection need long-term low-dose medical management like 50 milligram of nitrofurantoin for 2 months or 3 months. So recommendation for recurrent urinary tract infection, that is again guideline from 2024 European Urology. So how to diagnose a recurrent urinary tract urine culture? Yes, strength or recommendation is very strong. Use of vaginal estrogen replacement to prevent recurrent urinary tract infection in postmenopause, yes, strong. Like immunoactive prophylaxis to reduce recurrent urinary tract infection in all age groups, strong. Use of D-mannose and cranberry extract to reduce the recurrent urinary tract infection episode is weak, as discussed by Dr. Francis also in the previous presentation. The take-home message in uncompleted urinary tract infection is patient education, identification of symptom and urine testing, fosfomycin 3 gram single dose in women and Septron double strength for 7 days in men is the treatment choice. Persistent symptom, if symptom persists, then you have to get a urine culture. There's no role of imaging or cystoscopy in uncompleted urinary tract infection. And if the patient presents with a recurrent urinary tract infection, low dose prophylaxis is given to the patient. Thank you. Any question, please?
Yeah, it was an excellent talk. I have a few questions
Yes, ma'am.
before we proceed on to the further questions from the audience. So you had written risk factors for UTIs, history of UTI in mother.
Yes.
Wanted you to elaborate on that?
Ma'am, it is mainly the genetic factors which is there, okay? Because if whatever the study has been done, if the mother have UTI, so the transmission of the gene factor, particularly the blood grouping, the ABO blood grouping is there, or fucosilation of A negative, B negative blood group, that transmitted to the child. So those patients, they have more chances of the UTI in child.
So what is the frequency of this genetic disorders causing?
It's very rare, ma'am.
Right. So when school children come to us that they have frequent UTI, so what is the role of the public toilets? Do you think that contributes to this
No,
UTI?
ma'am. It is a myth, what I consider, because there is no studies, because most of the patient, they come that I have used the public toilet is because of that. No, it's most of the time because the patient, when the patients or the person are traveling, they are drinking less water, most of the time they're stressed out, so these are the factors, dehydrated. So they may have symptoms like dysuria, frequency, urgency. So it's not related to the public toilet at all.
What is the role of flavate, cranberry juice, and alkalinizer in UTI?
It's cranberry, ma'am, again, it is not clear. The guidelines say it is just, they not confirm it at all. But some, what you told, this one, alkalinizer, again, nowhere it is mentioned or guideline doesn't recommend it. It is just, publicly we are using, most of the time the patient are saying dysuria, and some, I have seen many times they are just giving some cranberry with D-mannose, or they are giving some citrate or potassium citrate solution. But overall, I will say it may act as a placebo, but the guideline recommendation is not there anywhere.
The last question, what is the post-coital antimicrobial agent you like to use?
Post-coital, for that, I will use that this one, nitrofurantoin 50 mg, okay, or even the patient can, the person can use it as self-administration dose also, 50 milligram nitrofurantoin single dose in the night for 3 days.
Right, and when we say that the patients should not be using the local lubricants like V-wash and all, what is their role?
I didn't get you, ma'am. Can you rephrase?
There are certain washes that the females use to keep the area clean, like V-wash,
Yes,
and that depletes the vagina and the vulva of the normal microbiota. So if they are frequently using that, what is their role in contributing to UTI?
Ma'am, they change the pH of vagina, because normally the vagina have lactobacilli and the corynebacteria, which normally cause the vaginal pH acidic. So if frequently the people use it, obviously the vaginal pH will become the alkaline and the lactobacillus strength will come down. So there will be more chances of developing UTI in those patients.
Hi, Uma. Very nice presentation.
Thank you, sir.
I just want to say, can you elaborate what are the preventive factors to avoid the recurrent UTI in the normal population, like public? What are the take-home message you are told, like the water intake and the things, what should we do to prevent the recurrent UTI in the local public?
So to prevent is, first thing is adequate hydration. Okay. There are some factor also that some people, the cranberry juices, okay, now it has changed into that. So again, it's the placebo effect. So hydration is first, okay. Then whenever they are using, suppose, particularly in the ladies, okay, when they are washing, it should be from the front to back. Most of the time they are not taught like this, because mother doesn't taught the next generation. So if these are things cut down, obviously I think the public will be made more aware, and the chances of this uncompleted urinary infection will be decreased.
Thank you.
Thank you.
Open for discussion. Any questions from audience?
One last question.
Yes, ma'am.
When patients say हमें morning में sample देना, we always say midstream clean catch, which could be at any point of time. Or do you want it to be the morning sample when the concentration of bacteria is the highest?
Yes, ma'am. The very nice question. Urologists normally say that we should get the first morning sample because at that time the concentration of bacteria is very high in the urine. Though for the urine culture, we normally say, because most of the time the patient present to your clinic somewhere in the afternoon or in the evening, so we normally say, okay, get the midstream clean catch. But recommendation, what the guideline also say, they should the first sample in the morning because the bacteria concentration is very high in that.
Excuse me, sir.
Yes.
I had a question.
Sure.
We see clinics patients. That time, if a urine report is showing pus cells of 5 or 6, and the culture is negative, what would be a treatment plan? And also role of nitrates.
Okay. So nice question again for the audience. See, what I told is we treat the symptom. We never treat the reports. Okay. So if the urine routine show pus cell, okay, if everywhere, the patient also comes to you with the report, sir, I have pus cell in my urine routine. So you have to ask whether symptom is there or not. Okay, so symptom is there, you treat. If no symptom, because normal urine also show some WBC, 3 to 4 WBC will be there. Okay, so normally it will be there. So treat the symptom, run the report.
Thank you, sir.
Okay.
So thank you for an excellent talk.
Thank you, ma'am.
Okay. Going on with the tradition, 2 questions to the audience. Please raise your hand and answer one at a time. In keeping with the last question which came from the audience about WBCs in the urine, can any one of you tell us the significance of sterile pyuria? Disease or diseases? Sterile pyuria. Anybody? If you don't raise your hand, you don't get the prize. I'm sorry, I couldn't hear it. I did hear it, but yes, please. Last. Correct answer. Sterile pyuria is a scenario where your urine culture, a routine routine culture will be no growth, but your urine will show WBCs beyond a point. The other 2 diseases which you need to chase if you have sterile pyuria is a malignancy inside, or if there is a stone or any kind of inflammation going on, right? Or if the patient has recently been treated with high dose antibiotics, his culture will be negative, but he will continue to have pyuria till his inflammation of the urinary tract settles. But TB in our scenario is equivalent to sterile pyuria unless otherwise proven. Okay, another question. Can somebody give me the definition of recurrent urinary tract infection as presented by Dr. Umakant in 10 minutes ago? Anyone, आप चूज करो किसी को जो भी पास खड़ा है पास बैठा किसी को भी दे दो.
Urinary tract infections more than 2 in 6 months or more than 3 in 1 year.
Congratulations, good answer. Right, more than 2 in 6 months or more than 3 in a year.
Both of the winners from audience can come forward, and I request the chairpersons to please give away their prizes.
Now I request Dr. Kim Maman to felicitate our guest speaker, Dr. Umakant Dutt. Now I request Dr. Kim Maman to felicitate our chairpersons, Dr. Ashish Jindal and Dr. Ashima Taneja. Now I invite Dr. Joseph John, Dr. Lydia Solomon, and Dr. Varun Sood to please come on stage and chair this session. The next session is by Dr. Chinmay Agarwal. She is a medical oncologist and hematologist at Sarvodaya Hospital, Noida. She is a pioneer in the field of chemotherapy, targeted therapy, and immunotherapy in solid malignancy and hematological lymphoid malignancies. She is a member of Association of Radiation Oncologists of India. She is a member of Indian Society of Medical and Pediatric Oncology, European Society of Medical Oncology, American Society of Clinical Oncology. Now I invite her to come forward and deliver her talk on urinary tract infection in immunocompromised patients. Thank you.
Good afternoon, everyone. First of all, I would like to thank everyone, the organizing committee, to have me here. So I have kept my talk very general and not a very cancer-specific talk. And I think some of the slides are overlapping with Dr. Umakant sir as well. So I'll be taking through what are actually the urinary tract infection, what is the pathogenesis, risk factors, clinical presentation, diagnosis, and some specific things like how we deal in oncology and what is the prevention towards it. Starting with the urinary tract infection, it is just a very broad term to mention it that it's a urinary tract infection. However, it should be very much categorized that which part of the urinary system is involved, whether it is kidney, whether it's ureter, it's urinary bladder or urethra, or the adjacent structures like the prostate. And because each and everything has a different course of action, has a different etiopathogenesis, has a different treatment as well. And most common amongst every infection is the cystitis and urethritis. So usually, initially before the antibiotic era, when the antibiotic resistance was not that much common, so it was usually a one microorganism which is causing the UTI. However, the patients who are like having a prolonged hospital stay, having predisposing renal conditions, and the immunocompromised patients as well might have multi-organisms UTI as well. Coming to the pathogenesis, basically there are the two routes how the urinary tract infections can be caused. The number one, which Dr. Umakant already mentioned, it's the ascending route, where the enterococcus pathogens from the rectum colonize the urethral area. From there, they ascend towards the ureter, then to bladder, and even to the kidney. However, there is another route as well, which is called as the hematogenous route, where the seedings from the hemat route can seed the kidney and cause the pyelonephritis as well. Coming to the most common pathogens of UTI, the most notorious is the E. coli. We all know. It is around 80 to 90% of all the urinary tract infections which is caused by the E. coli, followed by Klebsiella, Proteus, Pseudomonas as well, then Cons, Streptococcus and Staphylococcus. In my practice, whenever I am suspecting UTI, it is always either E. coli or Klebsiella. Coming to the risk factors, there are multiple risk factors which have already been mentioned. For our patients specifically, that majority of the patients, especially when the bones are involved and all, they have their, the power is very less. They don't have control over the bladder. So they are on the permanent catheterization. So indwelling urinary catheters are one of the risk factors for the recurrent UTI. Then yes, women already, we know because of the shorter urethra, they are much more susceptible towards the UTI. Then genetic in the family history, lack of water intake. Now one more thing, like Madam Ashma was mentioning about, what do you think, like why children are so much susceptible to UTI, and is it the public toilets? I think there's one more point towards it. So these days everybody is so much glued towards TV and all. So even if we get to feel that we have to urinate, we'll just keep sitting, okay, we'll be doing some dancing or the other, and just, okay, the suspense is left, just the suspense is left. Maybe that can also be one reason, like the children or even us, we are usually holding urine, and that could be a risk factor. Then improper hygiene, use of feminine douches and these sprays. Apart from the general risk factor, could be some medical issues as well, which could be diabetes, renal diseases, neurological bladder, prostatic hypertrophy, and the immunocompromised patients. Not only the congenital conditions, but the acquired conditions as well, which could be HIV or the oncologic issues, or the treatment per se. For example, patient is on some chemotherapy, or the patient has gone under transplant, or some radiation causing the radiation cystitis can also lead to UTIs. Coming to the clinical presentation, always the patient will have the urgency to rush towards the washroom, sitting there for hours together just for 2-3 drops to come down and causing a lot of pain, may have some fever, bad urine as well. However, like there are few symptoms which can help us to identify whether it's a cystitis, it's a urethritis, or it's a pyelonephritis. If at all there's a pain in the bladder region, frequent urination, urgency, painful urination, lower abdomen discomfort, or a dark urine, these indicate towards a cystitis. However, if at all there's a burning with urination, discharge, they indicate towards urethritis. Then pyelonephritis present more of a systemic disease, like having high grade with fever with chills, upper back and side pain, malaise, nausea, and vomiting also. So there was one, when I was making my presentation, I came across a very cute picture, cartoon picture that indicated that yes, UTI is a urethral terrorist incident. Coming to the diagnosis, which is like a common practice, like we'll be sending our CBCs, we'll send a urine RM, we'll also send urine culture, blood cultures as well, then the imaging, just to see if at all any other pathology is associated towards it. Coming to the lab findings of the urine reports, it could have bacteriuria, pyuria, RBCs in the urine, nitrate positive urine. So that indicates that nitrate reducing bacteria, which is the E. coli, or leukocyte esterase positive urine, then antibody coated bacteria. This also indicates the level of the infection, which is usually pyelonephritis in case of antibody coated bacteria. Coming to the complications, if at all you just leave it untreated, so it could lead to recurrence of UTI, permanent kidney damage, high risk of early delivery in pregnant females, urethral narrowing in men, prostatitis, or urosepsis. Then the management. So the usual goal is to provide a symptomatic and supportive treatment to eradicate the pathogenic infection, to prevent and treat recurrence, to identify and treat predisposing risk factors. So if we talk about the symptomatic and supportive treatment, we should always encourage lot of drinking and frequent emptying. Do not hold the urine. Antipyretics, if at all their fever is there, and a urinary analgesic also helps a lot. Coming to the systemic evaluation, usually it should depend on the culture reports, is how we proceed in our practice. We do start some antibiotic based on the symptoms. However, we do really wait for the culture report in our hands, because we are dealing with oncology on a daily basis and we don't want to complicate the things. The commonly used antimicrobials for the UTIs are nitrofurantoin, trimethoprim, sulfamethoxazole, fluoroquinolones, phosphomycin as well. Then the newer agents, cephalosporins, penicillins from quite some time, and the aminoglycosides. Now coming to the, what is the first line treatment or the second line treatment for a specific infection. For example, it's a acute uncomplicated cystitis. So first line usually, as the guidelines say, it could be nitrofurantoin, trimethoprim, sulfamethoxazole, phosphomycin. In the second line, you can use fluoroquinolones. In the urethritis, you can use ceftriaxone plus azithromycin or doxycycline. In the recurrent infection, there is also role of long-term prophylaxis, where the nitrofurantoin is given as a 50 mg dose per day for 6 months, and trimethoprim sulfamethoxazole is given in a half strength, which is 80 plus 400 for once daily for about 6 months. Then for uncomplicated pyelonephritis, first lines is the fluoroquinolone, second line trimethoprim sulfamethoxazole. Then acute complicated pyelonephritis is a amoxicillin, clavulinate, fluoroquinolones, and then prostatitis again trimethoprim sulfamethoxazole and fluoroquinolones. Having said that, still, I do really depend on my antibiotic sensitivity report before starting on any IV antibiotics. Coming to the prevention of the UTI, drink plenty of waters daily. Do not hold urine. Proper hygiene is a go-to practice. Avoid using irritating feminine douches. Wear loose clothes to promote air circulation. And there's now upcoming role of cranberries. So literature as of now haven't confirmed any definitive treatment about cranberry, but I'll tell you, we as oncologists, we do give cranberries as a placebo effect, whatever it is, but it does something or the other. We all know how it acts. Like, it helps the bacteria not to colonize over the epithelium, and also it makes the vaginal pH acidic, and hence again not allowing the bacteria to grow there. Apart from that, not using cranberries, one more thing I would like to point out is the use of probiotics also is a very beneficial in these days. It will again help the lactobacillus to be in the vaginal area to make a good amount of that, and helps to prevent the UTIs. The take-home message will be, it should be a prompt recognition. Early treatment is the key. Then obviously prevention is better than cure. Seek medical attention if at all you have any symptoms, and do prefer lifestyle considerations. Thank you.
Thank you, ma'am. That was a lovely talk. Ma'am, I have one or two questions. Ma'am, normally asymptomatic bacteria we don't treat, but in an immunocompromised patient or a post-transplant patient, do you start treatment and then wait for the culture, or do you treat
if
or
at
not
all the
treat?
patient is symptomatic, we really
Still
start on treatment, yes. And if at all once the culture report gives us some pathogen, then we do definitely
So we treat ABU
we
in,
do,
in
yes,
immunocom.
yes, yes.
And ma'am, do
absolutely.
we still use fluoroquinolones, because there's a lot of resistance now in our
If at all, if we are lucky to have it sensitive, then we do use as
So
a
that
second
is
line, obviously not as a first
So
line.
we don't start off with a fluoroquinolone.
No, not
according
at all,
to the.
not at all.
Okay. And when a immunocompromised patient comes to you with a transplant patient, we think of an MDR organism, or you start off with a simple antibiotic like nitrofurantoin?
We do start with a simple antibiotic
and
only,
then
and
wait
we'll
for the
wait
culture
for the culture,
report.
definitely, yeah.
Ma'am, in immunocompromised patients, is the incidence of fungal urinary tract infections more? We usually in OPDs find fungal infection commonly in immunocompromised patient. In your OPD, do you find more
Not
of
very
fungal?
common, no.
And
not
the
very
management is, how is it different?
Then we do add antifungals. If at all we have any
On a culture.
fungal, yeah, absolutely, we do add, yes.
So from a hematologist point of view, we interact with the urologist on 2-3 struggles we have. One is the hemorrhagic cystitis point of view, that is no
Absolutely, sir.
infection.
Yeah.
The second is the BK virus infection.
Absolutely, yes.
Any
yes.
suggestions from your side how to prevent
So
it?
in my residency days, we did had one ALL patient who went for a transplant. Then we discharged him with no symptoms and all. Came back to us within 2 days with frank hematuria. We sent all the cultures, and that patient came out to be BK virus positive. And I can tell you how it was a horror for all the residents to manage that time. That was the only patient I saw of BK virus. And we did give cidofovir for that patient. And yes, the urology people were on board for repeated drainage of the irrigation of the bladder. Yes.
So, from our point of view, where we struggle is generally the MDRs, escape
Absolutely.
organisms, and this BK is the other area. And of course, some simple things, take home for immunocompromised to avoid phimosis. And they may come with recurrent, but the resident has not checked it. So I just want to ensure that these are talked about in meetings.
Yes, sir. Yes.
Anybody else from the audience who want to ask a question or give a comment on her presentation? Cranberries have been recurrently discussed. So last speaker said there is no major, evidence. So in oncology patients, we generally avoid thick-skinned fruits, but cranberry juices, is it something which you want to give on a routine basis?
We do ask them to have a packaged cranberry, because that is the only thing I think available.
Partha was shaking his head, so maybe.
So a couple of things which, we, as urologists, as per our guidelines, we are slightly different in the take. One is the first thing which maybe medical oncologists, they tend to be on the safeguard to prepare, treat, but asymptomatic bacteria in immunocompromised patient does not require treatment because it's asymptomatic. So that's one thing which I would just like to clarify as per our guidelines. If we are planning an intervention on them, if they become symptomatic or develop COTI or whatever, then we need to intervene. That's the first thing. Second thing, cranberry as of now doesn't have any proven.
Evidence.
There are both meta-analysis, both proven against it. So finally,
It's like
they
the
said
papaya
there is
and thrombocytopenia.
Yes, it's inconclusive. So, like she herself said that they do give it, they don't know whether it's got a placebo effect. It's got no harm definitely, but if you do give it, I mean, it works with whichever.
So, we heard from medical oncologists, from a urologist point of view, for a hematology or a hematologist or an oncologist, is there anything you would want to tell us that we must do this to the patients and tell them this?
The first thing, which we would, in an oncology patient or hemato-oncology patient is avoid catheterization till the point possible. That's the most important thing. Secondly, if we are catheterizing, make sure a person who knows how to catheterizes. There is no particular role of the whole betadine washing, and that it's actually counterproductive sometimes. And you decide till where the patient needs the catheter and remove it. These are the three things. And generally, if, like we are going to discuss in the further things, catheter associated, sometimes I think Dr. Umakant also mentioned, if there is a catheter in place, so in statistics wise we say for every 10 days that the catheter stays inside the patient, the likelihood that he will have 100% culture is by 10th to 14th day. So by 10% there is a chance that he will have a colonized urine. Does that need treatment? No. If he is symptomatic, asymptomatic, it's called colonization. That's it. So we don't need to chase that. BK virus is always...
So when you say symptoms, is it fever or irritancy?
Symptoms can be fever, can be local tenderness, recent onset deterioration of vitals, all that. They may not mount a fever, they might be immunocompromised, but they might be local symptoms, all that. So that is something which we need to keep an eye on. That is where we come to the whole thing of catheter-associated UTI. Even if the patient has had a catheter and which has been removed to 48 hours, within 48 hours, and he develops these symptoms, that is also accounts for catheter-associated UTI.
So, in other words, for a COTI, what is the acceptable percentage in the qualities realm?
As in like so?
I mean, you said 10th day there's a 100% possibility of a colonization.
Colonization.
Now, in other words, to call it COTI, it is not colonization,
It
right?
is not.
It is only if it's symptomatic.
It is only if it's symptomatic.
As a benchmark, is there any allowed COTI in the hospitals?
So I mean, as minimum as possible. I mean, in my limited experience, we would find the patients who had a catheter and have had an intervention catheter removed. We would nearly 10-15% in a tertiary care institute like ours.
You are expecting.
We would be expecting, but we would like to keep it to the minimum, especially in a hemato-oncological and oncological setting. We would like to keep it
So,
much
if
lower.
you have colonization, should you remove the catheter, reintroduce another one?
So that brings us back to the why did you place the catheter in the first place? And is the patient, so the indication of the catheterization, and if the indication is over, you take out the catheter. You don't have to treat. If the patient has a good urine output, if he is generally able to wash out the bladder will decolonize itself soon. Or the urethra will decolonize itself
So,
soon.
if catheter needs to be there, it can be continued even if it is colonized. That's the
Of
answer.
course, yes.
Okay.
If the catheter needs to be there, till the time it is necessary, you keep the catheter and you take
Even
it
if
out.
there is a colonization.
Absolutely.
Okay.
Absolutely.
So, colonization is.
does not. So that is why the whole guideline of a Foley's catheter versus a rubber Foley's versus silicone catheter. If it's a rubber Foley's catheter, we generally say catheters needs to be changed about once in 4 to 6 weeks. We can stretch it to about 4 to 6 weeks. If it's a silicone catheter, it can be changed once in 3 weeks, once in 3 months.
So, it is not 2 weeks. It is.
We can
I
keep
mean,
it up to
rubber
4 to
is
6 weeks.
4 to 6 weeks.
4 to 6 weeks, yes. Yes, we can change it 4 to 6 weeks. Only thing is, if the catheter, so the problem which happens is, when a patient is on a catheter, what can be the death sentence for the patient is if the catheter starts getting blocked. So if the catheter starts getting blocked, it can be either because the patient is not drinking enough water and it's forming crusts, or there are these which people are worried about, this cloudy urine, this pus in the urine, this whole thing. So that can clog the ureter and then the Foley's catheter, and that can be counterproductive because the moment there is clogging, the colonization has a chance to get bacteremic because the bladder gets distended, there is mucosal ischemia and there is translocation. So if the catheter is generally drained, so when a patient is immunocompromised or a patient is catheterized, one of the key things we tell them is to make sure that he has his adequate, urine output is adequate, provided his renal function, everything. And the second thing is they need to learn how to recognize the signs that his catheter is getting blocked. We even teach them to milk the catheter every now and then so that whatever debris keeps getting washed out. These two things, if we are doing, we can keep a catheter, and there is no role for pericatheter, betadine and all that. It's actually counterproductive.
One last question. External catheterization with the condom catheter, is that okay, not okay? Is that predisposing to infections more?
If you have to have a catheter, an indwelling catheter is best for urine output monitoring. If you are just looking at collecting how much urine the patient is voiding, and you have a very strong nursing setup where they can realize that when the skin is getting macerated and all, they can pick it up early and change, condom catheter is fine. But
Convenience, essentially.
Condom catheter is any day, but if you're
It is
looking
okay.
at long-term catheterization, more than 48 hours, we would say put in an indwelling catheter or put an SPC.
Okay, so if you, for convenience, you can put in an external, but if it is to be for more than
a couple of days and all, then an indwelling is much better than a condom, because the condom comes with its own problems. The fact that it keeps coming off, the fact that it relies on the patient to void, it causes maceration of the penile skin and all that. So indwelling versus condom, definitely indwelling much more, and between the two as minimum, and make sure your indications are sorted out.
Thank you so much.
One thing you can do in recurrent urinary tract infection or complicated infection is the change of pH of the urine. That is something which you can do it. We can change the pH of the urine. Whichever pH is there, you can change it. If it is acidic, which you can change it. This is for high-risk patients like patients in transplant unit or patients who are refractory to antibiotics. You can.
So in other words, you are saying use citralca in these patients or any other alkalinating agent in patients with UTI. Does it help if the patient is on sodium soda bicarb infusion already? Do we need to give citralca?
You can check the pH of the urine.
Keep it more than 7.
Yeah.
Okay.
Can I ask one last question? Ma'am, normally if a patient in the ward, if they have candida in the urine, we normally don't treat it. We just remove the catheter on it. For if an immunocompromised, if required, yeah. Required. Yes. Or not to treat. But in an immunocompromised patient, a post-transplant, if a candida comes in the urine, should we aggressively treat or still we'll have to treat?
Candida is one point where, so the candida is one place where you would want to have a lower threshold for treatment. Again, you need to check.
So post-transplant patient, hematologically transplant or a solid organ transplant, colonization of the urine with candida, would you remove the catheter or treat or do both?
We can give a chance with a change of catheter and see if it clears. If there are fungal balls inside the urinary system, then we definitely need to treat. If there are fungal balls which are causing blockage of the urine, we need to change, even give a wash with antibiotic cover. But if it is asymptomatic with just the candiduria, you can go on conservative if there are no active signs of
put a new one.
Sometimes that helps because the catheter, the foreign body itself kind of becomes a nidus for it. Candida is something which is always difficult for all. Even the BK virus that you mentioned, just like she correctly said, it's a nightmare for both the urologists and the hematologists to treat. There is no doubt about it. Okay, audience question time. Quick question. What is the first line for a treatment for uncomplicated acute cystitis? Anybody? She mentioned it. Ma'am, teachers are excluded from getting prizes. Sorry. Okay, I'll ask the second question. Okay, if there were two pointers which you would like to tell your female patients, this is for students only, to prevent urinary tract infection, what would you tell them? 2 pointers, which she elaborated upon very beautifully. Yes, she's been trying for a while. Yeah, please.
Drink more water and frequent urination.
Fantastic. So don't hold your urine and drink enough water. So the one thing which was asked in the previous session, this whole business of public toilet versus this thing, one of the problems which causes the urinary tract is not the public toilet, is the avoidance of voiding because of the public toilet or the toilet in the school. Girls will not go to the loo, they will hold their, we have had nurses coming to us saying they have held their urine for 8 hours continuously. Because that distension which happens in the bladder, it causes the pressure to rise inside the bladder. It causes ischemia of the mucosa because of the raised pressure, and that causes translocation and the rest. Right? Any other things which you can ask patients to do to prevent? Yeah, you've also been trying, right? Yeah, go ahead. Correct. So basically perineal hygiene, and one thing which we tell in elderly patients is prevent constipation. Because the constipation itself can cause hard stools, they will not defecate properly, they will have stool smear in the perineum, and when they wash, it's basically the logic being you want to drive the bacteria away from the urethra and not bring perineal or perianal bacteria to the anterior perineum. Right, both of them can.
Thank you, Dr. Chinmay, for this wonderful presentation. Now, I request Dr. Kim Maman to please come forward and felicitate our speaker. Dr. Chinmay, please come forward. I would request Ms. Sharon to please hand over the token of appreciation to them. Next, I'd like to request our chairpersons to please come forward, and I request Dr. Kim Maman to please stay on the stage to felicitate them. Dr. Lydia Solomon, please, ma'am. Yeah. Dr. Varun Sood. Dr. Vaibhav Sood. Sorry, sir. Dr. Joseph John, please, sir. Now I request Dr. Archana and Dr. Isha to please come forward and collect your prizes for the quiz. I request Dr. Nitin Agarwal to please come forward and hand over the prizes to them. Thank you, sir. For our next presentation, I would like to call Dr. Ashima Taneja, Dr. Vinita Agarwal, and Dr. Varun Watts to please come on the stage and chair this session. This session is going to be by Dr. Kavita Bhatti, the professor and head of Department of Obstetrics and Gynecology at CMC Ludhiana. She is also Vice President of Ludhiana Obs and Gynae Society, President of Ludhiana Menopause Society, Secretary, Punjab Chapter, North India Gynae Forum, Editorial Board Member in various national and international journals. She has also won numerous awards including Best Clinical Teacher Award in 2017, Wonder Federation of Obstetrics and Gynecology Societies of India Award in 2019, Manyata Champion Award in 2020, Federation of Obstetrics and Gynecology Societies of India Achiever Award in 2023. I invite Dr. Kavita Bhatti to please come forward and deliver her talk on urinary tract infections in pregnancy. Thank you, ma'am.
So thank you for the introduction. And since morning we have been talking about men's health, let us focus on women's health, particularly the antenatal mother. And I'm very grateful to Dr. Nitin Agarwal sir for keeping this slot, which will be focusing on the health of the antenatal mother. So I'll be talking about urinary tract infections in pregnancy. Now we commonly see this condition in our OPDs, but as quoted by ACOG, that is the clinical census which was published in August 2023, it affects 8% of pregnancies. Up to 15% of women will experience one episode of UTI at some point in their lives. And this urinary tract infection can either be symptomatic or asymptomatic. It is a wide spectrum of urinary tract infection during pregnancy, which we need to recognize and treat. So it can be either asymptomatic bacteriuria, acute cystitis, and a more serious condition that is pyelonephritis. It can also be classified based on the site of infection, that is lower urinary tract infection, which constitutes asymptomatic bacteriuria or cystitis, or the upper urinary tract infection, which is pyelonephritis. The incidence is 2 to 10% of pregnant patients, if most of them presenting with asymptomatic bacteriuria. 1 to 2% will present with acute cystitis, and 1 to 2% again acute pyelonephritis. Pyelonephritis is one of the most common medical cause for hospitalization, especially during pregnancy, if they have urinary tract infection. And it is seen to be most common during the second trimester of pregnancy. Now, during pregnancy, there are various anatomical and physiological changes which occur in the urinary tract and which predisposes the antenatal mother to infection. One is urethral dilatation, because under the effect of the hormone of progesterone. Also the gravid uterus, which compresses on the ureter, leading to increased residual volume in the bladder and urinary stasis. This results in vesicoureteral reflux, which adds on to the colonization of the bacteria. There's increased glomerular filtration rate and urine output due to the increase in the blood volume expansion during pregnancy, which leads to decreased osmolarity of the urine and therefore the urine becoming alkaline. Urine stasis because of, from an increase in urine output volume and the lack of urethral tone adds on to the incidence of urinary tract infection, and also because the glucose reabsorption is affected by the proximal collecting tubule and the loop of Henle, which leads to glycosuria. So that also predisposes the patient to bacterial colonization and ascending infection. Now, what are the risk factors for developing UTI in pregnancy? Sexual activity, low socioeconomic status, increasing age, urinary tract abnormalities, diabetes, sickle cell disease, poor personal hygiene, and catheterization. And it is seen that it starts as early as 6th week during pregnancy and peaks between 22 and 24 weeks, but may present later as well. The common infecting organisms we all know is Escherichia coli, that is 70 to 80%, Klebsiella 5%, Enterobacter 3%, Proteus 2%, and a more important Streptococcus, which is group B beta hemolytic, in 2 to 5% of cases. What are the adverse pregnancy outcomes which can be because of urinary tract infections? One, we are worried about the preterm delivery, premature rupture of membranes, low birth weight, and fetal growth restriction, and also certain maternal complications such as sepsis, DIC, and acute respiratory distress syndrome. Now let us focus on asymptomatic bacteriuria. How do we diagnose? When there is clinically significant number of bacteria in the urine, but the patient is asymptomatic and clinically well. So what is significant bacteriuria? It is defined as 2 voided urine samples with greater than 10 to the power of 5 colony-forming units per ml of a single organism. It is commonly seen in early pregnancy, though some may present later during the second and the third trimester as well. So it is recommended by the ACOG that all pregnant women should undergo urine culture screening, which is the gold standard for detecting asymptomatic bacteriuria at least once during early pregnancy between 12 to 16 weeks. So at the first prenatal visit, it is mandatory to check all pregnant ladies for asymptomatic bacteria by doing a urine culture. There are other methods also which are available, like a routine urine dipstick testing for infection, but it is seen that it does not have any benefit and is not sufficiently sensitive to detect asymptomatic bacteria. So the best method is to do a urine microscopy and a midstream urine culture at the first antenatal visit. Both midstream and midstream clean catch. So there's a difference between the two. it is seen that they both have a similar rate of vulvovaginal bacterial contamination. So mostly in our antenatal OPDs, we will be telling them about midstream, wash and then take a midstream urine sample. But according to the ACOG, there is no evidence specifically addressing this, whether to repeat a sample that demonstrates vulvovaginal bacterial contamination. So a midstream is as good as a clean catch midstream urine sample. When the urine culture comes negative for asymptomatic bacteria, is additional testing required? It is not indicated because the risk of pyelonephritis is low. But in some higher risk populations, such as immunocompromised patients, one can screen it more than once. What is the treatment? We need to treat all asymptomatic bacteria during pregnancy. So a 5 to 7 day course of targeted antibiotics is essential, especially if the colony count is 10 to the power of 5 or more. Lower counts may represent contamination and do not require treatment. So there's insufficient evidence, as said by the guidelines, to recommend for or against repeat screening after appropriate treatment of an initial episode of asymptomatic bacteria. Now, often we come across group B streptococcus infection. So if present in counts of more than 10 to the power of 5, we need to treat. But if it is lesser, one must remember, though it may not require treatment at that point of time, but during delivery you need to give group B streptococcus prophylaxis in the form of ampicillin. Sometimes the urine culture might show normal vulvovaginal flora such as lactobacilli or cornybacteria, coagulase negative staphylococcus, so these should not be treated. Untreated asymptomatic bacteria can result in symptomatic UTI, and up to 20 to 40% of women can develop this, and hence the treatment is essential. So what antibiotics to give for asymptomatic bacteria and cystitis if it develops? The first and foremost is nitrofurantoin, 100 milligrams orally every 12 hours for 5 to 7 days. And avoid this treatment, especially if you suspect pyelonephritis, and also in the 3rd trimester, because it has been seen that in some babies who are G6PD deficient, there could be hemolysis and they can present with hemolytic anemia after birth. Trimethoprim should be avoided in the 1st trimester because it increases the risk of miscarriage. The other antibiotics are cefalexin, sulfametazole, trimethoprim, fosfomycin, amoxicillin, and augmentin as well. Post-treatment of asymptomatic bacteria, should a repeat screening be done? There are no studies available that assess or recommend whether a test of cure should be indicated after treatment. But because these conditions are asymptomatic, then it is best to repeat after treatment. Postpartum UTI is likely to occur in about 25% of cases of asymptomatic bacteria that has not been treated in pregnancy. So it is better to test with a repeat urine culture after giving treatment. Coming to acute cystitis. It is defined as significant bacteria with a single organism on a urine culture associated with symptoms. So here the patient will be having symptoms such as dysuria, urinary frequency, urgency, nocturia, hematuria, and suprapubic pain. But always remember that some of these symptoms, especially frequency, urgency, and nocturia, are also seen in early pregnancy, so need to differentiate. It is more common in women with diabetes and those who are immunocompromised and those who have had previous episodes of urinary tract infections. Now, how to diagnose? Nitrites and leukocyte esterase are commonly found on urine dipstick, but this is not recommended by the ACOG guidelines. The gold standard is to do a urine culture, and the threshold, as already mentioned, it is 10 to the power of 5 colony forming units per ml. But when there are symptoms and you clinically suspect, along with the presence of nitrites, you can still initiate the treatment with antibiotics. Now, this is a table which shows the accuracy of urine analysis to predict culture positive UTI. So if you see leukocyte esterase has a sensitivity of 72 to 97%, and if protein are present more than 3+, then again the sensitivity is almost 96%. More than 5 WBCs, more than 5 RBCs, they have varied sensitivities, higher for the presence of pyuria. And if there is bacteriuria, then again sensitivity of 46 to 58%. Now, how to treat cystitis? The essential components of care involves choosing the appropriate antibiotic and treatment for an appropriate duration with antibiotic. But along with this, you have to wait for the culture results and susceptibility, and also look at the safety profile, especially during pregnancy. So the treatment duration is 5 to 7 days. You can start the patient on empiric antibiotic therapy so as to relieve them from the symptoms, but always remember you have to wait for the culture report and tailor the antibiotic treatment accordingly. If started before culture and sensitivity report, then avoid amoxicillin and ampicillin regimens due to high rates of resistance to E. coli, which is the common organism in UTI. In the presence of symptoms, treatment for colony counts as low as 100 of a single organism, you can still initiate antibiotics. Nitrofurantoin is the treatment of choice in lower urinary tract infections because it has lower resistance rates, it is effective against many pathogens which are common in pregnancy, and it also concentrates and achieves therapeutic levels in the bladder. Single-dose phosphomycin has been compared to nitrofurantoin. It has similar clinical outcomes and effective with higher compliance. But one should remember that both these drugs do not reach adequate tissue levels within the kidney and should be avoided if the diagnosis is uncertain, when you do not are unable to differentiate between cystitis and pyelonephritis. Post-treatment, what are the options? So each episode of acute cystitis can risk the progression to pyelonephritis. Consider repeating a urine culture 1 to 2 weeks after completing the treatment or if the symptoms recur. And there is insufficient evidence regarding the risk or benefits of either strategies which are lacking. So what are the two strategies that we follow? One is the post-coital strategy, that is antibiotics taken before or after vaginal intercourse. And the advantage of this is that the adverse events related to antibiotic use is low, especially when you are giving it to the pregnant lady. Or you can put these patients on a continuous prophylaxis using a single daily dose of antibiotic to which the bacterium isolated was susceptible. So common suppressive regimens which are recommended is nitrofurantoin 100 milligrams daily or cefalexin 250 to 500 milligrams daily. This is also recommended for recurrent UTI. And what is recurrent UTI? It is defined as having 2 or more UTIs diagnosed during pregnancy, and you can see at least 4 to 5% of pregnancies being affected by recurrent urinary tract infections. Coming to pyelonephritis, which is a more serious condition of infection in the urinary tract. This is the infection in the urinary tract which results in inflammation of kidney and renal pelvis. Again, the common organism is E. coli in 80%. More frequent on the right side, can be bilateral up to 25% of cases, and is common in the second trimester. Factors predisposing to pyelonephritis: immunosuppression, pre-existing diabetes, sickle cell anemia, a neurogenic bladder, frequent or chronic UTIs, tobacco use, age less than 20, and delayed prenatal care. So what is pyelonephritis? How do we diagnose? It is suspected when a midstream urine culture identifies at least 100,000 bacteria per ml of a single uropathogen with concomitant inflammation of the renal parenchyma, calyxes, and pelvis in the presence of systemic illness. So here the component of systemic illness is added to get to the diagnosis of pyelonephritis, and these can present as fever, rigors, abdominal pain, flank pain, nausea, vomiting, and headache. A fever of more than 38 degrees or higher, one should suspect pyelonephritis. And how to go about the investigations also, you have to do urinary studies which may suggest urinary tract infections. Additional symptoms could be flank pain, costovertebral angle tenderness, and one also needs to do an ultrasound, especially to look for abnormalities which may be leading to pyelonephritis. So a complete blood count Urea and electrolytes is recommended. Midstream or catheterized urine specimen, which includes urine analysis, urine microscopy, and culture. Blood culture can be done, though the duration and management will not differ. Renal ultrasound to identify hydronephrosis, urinary stones, or urinary tract abnormalities. Differentials include nephrolithiasis, renal abscess, urosepsis without pyelonephritis, and chorioamnionitis. The complications seen during pregnancy: increased risk of preterm labor, premature rupture of membranes, low birth weight, anemia, preeclampsia, septic shock, and in the mother, acute renal insufficiency, ARDS, pyonephrosis, and very seldom perinephric abscess. Timely recognition and diagnosis is very important for managing pyelonephritis, and the initial management should always be done in patient setting. Fluid hydration and initiation of intravenous antibiotics, you can put them on empirical treatment, but always remember to change according to the urine culture sensitivity report. So for the first 24 hours, you need to give parenteral antibiotics, though the total coverage of antibiotics should be for at least 14 days. Patients may require analgesia, NSAIDs to be avoided because it can lead to ulcers in the mother, impaired renal perfusion, oligohydramnios, and early ductus arteriosclerosis in the fetus. Some mothers may require thromboprophylaxis in case of prolonged restricted mobility, tocolysis in case of preterm labor, and antenatal steroids. What are the regimens that are followed for pyelonephritis during pregnancy? Ampicillin and gentamicin, which has been quoted by ACOG, though I have apprehensions because gentamicin usually we avoid during pregnancy because of the ototoxicity. Ceftriaxone, cefepime, and estronam are the other antibiotics which are recommended. So these have to be given at least for 24 hours, and one should always look for clinical improvement. What is clinical improvement? It is defined as being afebrile with improvement of symptoms for more than 24 hours. So this is usually seen in 75 to 95% of the cases within 48 to 72 hours of initiating the intravenous antibiotics. If there is no clinical improvement within 72 hours, then you need to evaluate for bacterial resistance and imaging to rule out other causes of urinary tract infection. Antimicrobial resistance is one of the most common reasons for treatment failure. After clinical improvement, you need to complete the course of appropriate oral antibiotics for 14 days based on the culture sensitivity. Nitrofurantoin and fosfomycin are not appropriate oral agents, especially for pyelonephritis, because, as I said earlier, it fails to achieve the therapeutic levels in the renal parenchyma. Urine culture should be obtained after completion of antibiotics to ensure no residual infection persists. Post-treatment, there's insufficient evidence to guide management after treatment of pyelonephritis in pregnancy, but one should also consider suppressive therapy for the remainder of the pregnancy, as mentioned in the previous slides for recurrent UTI. One can also see recurrent pyelonephritis, which occurs in 25% of pregnant patients before delivery. So post-treatment suppression is very important. Suppressive agents selected should be matched against the susceptibility profile of the pathogen isolated in the urine culture and continue the antibiotics to up to 4 to 6 weeks postpartum. They also recommend routine monthly urine culture to screen for recurrence, and that should be continued for the duration of pregnancy for recurrent pyelonephritis. Do not forget your urologist colleagues. You can always consult them if the UTI does not improve with antibiotics, if the patient is having recurrent UTIs and not getting appropriately treated, and if the UTI is complicated along with hematuria, urinary incontinence, or overactive bladder. So to conclude, significant physiological changes predisposes the pregnant lady to UTI, which can again be symptomatic, asymptomatic. Very important to treat asymptomatic bacteria during pregnancy. The gold standard for diagnosis is always urine culture, and because untreated UTIs can lead to severe morbidity, mortality in the mother as well as the fetus. Follow the 7-day dosage schedule, which is safe for the mother and the fetus. Thank you.
Thank you, Dr. Kavita. It was a lovely talk. My question to you is, how many urine routine samples do you ask a patient during pregnancy? And number two, how many urine cultures you advise to the patient as a routine?
Yeah, as a routine, urine routine and urine culture we advise on the first visit. Even if they come in the first trimester or whether they're coming in the second trimester, that is done. Or if the patient presents with any symptoms suggesting a urinary tract infection, otherwise. Otherwise, it is mandatory that we check them in the first visit.
And urine routine, in how many visits do you repeat a urine test for that patient? For any patient?
Normally, practically, we are not repeating throughout pregnancy except for in the first trimester.
Right. The guidelines say that we have to do a urine routine for the patients at each visit, but it is very difficult.
Yeah.
But at least we can do one in each trimester.
Earlier, we used to do albumin, sugar, and microscopy, I remember. But now, because the patients do not actually agree for all these tests on the visits, we have stopped it.
My question to urologist, pregnancy with pyelonephritis, how do you interpret physiological hydronephrosis in this situation?
Can I answer that? Yeah, what I have seen is that physiological hydronephrosis is mostly on the right side, and it is one-sided. And if you repeat the ultrasound after a few days, it usually resolves. And it usually presents in the second or third trimester because of the gravid uterus, which is pressing more on the right side because of the dextrorotation. I will love the urologist to add to it.
Above the pelvic brim. But if there's obstruction because of stone or something else, the hydronephrosis will be till the ureteric orifice. So that's the way how we can differentiate between the physiological hydronephrosis or hydroureteronephrosis from the pathological.
And more of the urine culture will be negative.
Dr. Kavita, are you using phosphomycin in first trimester?
I am not using, but that is why I said most of the content of my presentation was from the updated ACOG. Even I could not find the Royal College of Obstetrics Gynae, an updated version. But practically we are not using phosphomycin.
In second and trimester, you've heard.
Yeah, if they are not being treated by the normal urine culture and they're coming recurrent with UTI, then we give phosphomycin.
So first line of treatment is nitrofurantoin for.
Yes, till you wait for the culture sensitivity report.
Yeah. So we have tried phosphomycin in second and third trimester with very good results, and nitrofurantoin can be used, as you said, in the first trimester if you don't have any other choice. Thank you, Dr. Kavita.
The audience is depleting, just to keep you guys with us. There are a few more prizes to go. 2 questions based on what Dr. Kavita just presented. So, scenario, patient comes to you with asymptomatic bacteriuria. You have treated the patient, and then what do you do following that? One answer. Shaking heads is not an answer. The PGs and the residents and the medical students who are there. Your patient comes to you with asymptomatic bacteria, you've diagnosed asymptomatic bacteria, you've treated it, and then what do you do after that to follow up the patient? Okay, answers, options being repeat a urine culture, nothing, continue antibiotics, which of the 3? Please raise your hand and answer. Yes, go ahead. No, that is what? In asymptomatic bacteria, you do not do anything else, like ma'am said, right? You just follow up the patient. Okay, another scenario, patient had pyelonephritis. Okay, treated with antibiotics for how many days as per the presentation? 14 days. Then what do you do? You need to document a repeat urine culture. Okay, so now the question comes, if the patient develops, the urine culture is still positive, but the patient is asymptomatic then, therefore, then what will you do? Ma'am did answer that question. That is the question now for you. You have treated active pyelonephritis in a pregnant lady. Patient becomes asymptomatic. You've given 14 days of treatment. You repeat a urine culture. Urine culture is positive, but the patient is asymptomatic. What do you do? Ma'am did mention something. Would you want to answer?
So your question was pyelonephritis treated, asymptomatic, but it's showing urinary infection. So obviously, I think the PGs will be able to answer if it's still showing the infection, especially in pregnancy when we are dealing with the antenatal mothers. So, can't hear you.
Prophylactic antibiotics, right? That's what
You have to give the antibiotics based upon the urine culture report and then continue it for throughout pregnancy.
No winners this time, we have next time.
Single dose is given, what we give in inpatients or outpatients, single dose at night, either nitrofurantoin or cefalexin. Sometimes we are giving cefuroxime as well. Dr. Ashima, you agree?
Exactly. We continue nitrofurantoin as a prophylactic antibiotic till at least 36 weeks.
Yeah.
I request Dr. Nitin Agarwal and Dr. Partho to please come forward and felicitate our chairperson and the guest speaker also, Dr. Kavita Bhatti also. I request Dr. Kim Mamen and Dr. Amit Tulli to please chair our next session. The next session is by Dr. Yogesh Kalada. Dr. Yogesh Kalada is a senior urologist at Deepak Hospital, Ludhiana, with specializations in endourology, reconstructive urology, laparoscopic urology, and uro-oncology. He has 20 years of experience in the field and has several publications and presentations to his name. I invite Dr. Yogesh to please come forward and deliver his talk on role of nutraceuticals in urinary tract infections.
Well, good afternoon, everyone. I thank the organizing committee of CMC and head of the Department of Urology, Dr. Nitin Agarwal, for having me here and giving me an opportunity to speak upon the role of nutraceuticals in urinary tract infection. From morning, we are discussing about urinary tract infections, and my fellow speakers, Dr. Uma, Dr. Francis, ma'am, everybody has given a very detailed explanation and about urinary tract infections, complicated, uncomplicated. But everyone has, in their talk, they have told that according to the studies, there is no active role, or there is no documented role of nutraceuticals in prophylaxis of urinary tract infection. So already before starting my talk, I am on a kind of a back foot. But yes, in their presentations, whenever the slide of urinary tract infection prevention or prophylaxis used to come, in the end, somewhere they have written a word cranberry. So that was a bit encouraging for me, that although there is no evidence, but still people are believing that, okay, you give cranberry, something will happen. Patients, they don't develop infection. So yes, I agree that there is no conclusive evidence. But yes, we should know how these things work, and who knows what future may hold for the nutraceuticals. Well, Hippocrates mentioned, first of all, just a quick recap of lower urinary tract infections. We have been discussing this since morning. It's a very common disease entity. It is a great public health concern, and around 60% of the women, in some point of their lives, they will be affected by UTI. And E. coli is the most common culprit in most of the cases. Well, Hippocrates quoted that let thy food be thy medicine and the medicine be thy food. So with this quote, he wanted to focus on prevention, but the concept of food as medicine is very old. In 1989, Dr. Stephen D. Flacy coined the term nutraceutical, which is actually nutrition plus pharmaceutical. So it is made up of nutrition and pharmaceutical. Nutraceuticals are basically defined as food or part of food that provides medicinal or health benefits, including prevention and treatment of the disease. There are many ways to classify a nutraceutical. It can be classified on the basis of natural source, pharmacological condition, chemical constituent. But the most common way in which we do it is based on the chemical group. Various groups are inorganic minerals, supplements, probiotics, prebiotics, dietary fiber, antioxidants, phytochemicals, and herbs. So coming to the urinary tract infection, we will focus on some top things that are actually into UTI, that are mainly cranberry, diminose, and some probiotics. Cranberry, basically the American cranberry or Vaccinium group, it was historically used by North American Indians to treat UTI. So what actually cranberries are composed of? They are composed of most of the 88% water, organic acids, fructose, vitamin C, flavonoids, acanthocyanidins, catechins, antiterpenoids. But the iridoid glycosides give taste to the cranberries, but what I will say the most active component is the pro-acanthocyanidins. So these are basically found in the Vaccinium berries and are known to have a natural plant defense mechanisms. So how do the common preparations of cranberry are basically juices, and nowadays prescribed is in the form of capsules which have both cranberry and diminose in it. So how do these cranberries act? So I would like to demonstrate this chart. So how does the main organism we know is the E. coli. So what E. coli does is, it all is based on the addition of the fimbriae or pili of the E. coli with the glycoprotein receptor in the urothelium. So that is the point where we have to inhibit this addition to prevent the UTI. So it is basically this addition mechanism that has to be inhibited. So again, what I already said, that important property of E. coli is that its adherence to the host tissue. Main protein structure related to this phenomenon is adenosine protein. And the pili or fimbriae, they get attached, this adenosine protein is mainly present on the tip of the pili and fimbriae, which get attached to the glycoprotein receptors. So this, just elaborating this pili and fimbriae a bit, that these pili can be either mannose sensitive or mannose resistant. The mannose sensitive pili, they are called type 1 pili, and these pili are inhibited by fructose, which is present inside the cranberries. There is another group of pili which is called as of a fimbriae that is called P. fimbriae, that is isolated from the patients of pyelonephritis or complicated UTIs. So here the pro-acanthocyanidins, these constituents of cranberry, they go and inhibit the P. fimbriae. They have a preventive role. Studies have shown that other organisms like Pseudomonas, Enterococcus, Klebsiella, in these kind of organisms also, cranberry has some preventive role in prophylaxis of the UTI. Cranberries are known to interact with certain drugs like flavonoids, aromatase inhibitors, and warfarin, but not that significantly. Although there are not much studies or trials to support what I am saying, but still, this is a very famous trial which was published in 2015 in a European Journal of Pharmacology, in which there was a randomization was done in cranberry and placebo group, and cranberry was evaluated in terms of reduction in frequency of UTI. We are talking about the prophylaxis and number of symptom-free patients and mean duration of UTI episodes. Everywhere it has some amount of benefit or some amount of upper hand to the placebo group. And 90% of the times in around 2 to 3 months of prophylaxis, the urinary sample was free of bacteria in patients given only cranberry. So, definitely cranberry has, on the basis of these trials, cranberry has some role in prophylaxis. Now coming to D-mannose. D-mannose is basically a hexose sugar monomer naturally occurring in simple sugar. It is present in cranberry and often used as a naturopathic remedy for UTI. And another use of D-mannose is given in carbohydrate deficient glycoprotein type 1b syndrome. The mechanism of action is same. It is basically by the inhibition. Here, D-mannose binds and blocks the FIM-H adenosine, which is located at the tip of the type 1 fimbria. Again, doesn't allow the bacteria to colonize with the urothelial wall. There was a trial published in World Journal of Urology in 2015. This is a very interesting trial in which randomization was done in 3 groups. Around 308 patients were taken. Group 1, the patients who were included were patients with recurrent UTI, and their active episode was treated. And after that, patients were randomized in 3 groups. Group 1 had 103 patients in which D-mannose was given and given for 6 months. And group 2, for prophylaxis, 50 mg nitrofurantoin was given, and both had 103 patients in that. And group 3 was placebo. So there was not much difference in the nitrofurantoin and the D-mannose arm. The side effects of nitrofurantoin were more, but the authors concluded that D-mannose has a good role, significantly good role in prophylaxis of recurrent urinary tract infection. So coming to probiotics, the idea here with probiotics is to just have healthy and friendly bacteria, more of friendly bacteria than the unfriendly bacteria. The researches are going on, and yes, not much conclusive evidences for probiotics are there, but people are prescribing this for prophylaxis along with nutraceuticals, other nutraceuticals. Main probiotic here of interest is lactobacillus. There are some polyphenols which are still under research, especially the caffeic acid. And we are awaiting some studies, apart from cranberry and D-mannose, studies regarding probiotics and polyphenols to come so that we can conclude something. Thank you.
Yogesh, good talk. And Amit, do you have any questions?
Certainly, you have discussed all the things what we have to prevent recurrent urinary tract infections. Other than these drugs, any research is going on in any other field or any upcoming drugs? Because we are regularly using cranberry extracts, D-mannose. Any futuristic drugs are coming?
Probiotics and flavonoids, they are being researched.
Okay.
But there are no studies available, very less studies available for same. Still, there are not many studies available for cranberry and D-mannose also, but still there are some.
No, but the pharma companies, they are promoting them like
They
anything.
are promoting like anything. Day before yesterday only, I was talking to a pharma guy. He was telling that the sales are good.
Yeah,
so
yeah.
this means that then only I was like thinking that this means that there must be some role of these products.
No, nowadays the urologist prescription includes, nitrofurantoin and cranberry extract also.
Both actually.
Yeah, both are
maybe
there.
people are prescribing both also.
Mm-hmm.
evidence in literature is weak for cranberry and D-mannose.
Yes,
but
that's
their business has gone up.
Their business gone up. That's why before the start of my talk only I told that I am on the back foot.
Just one question for the audience apart from the faculty. So which is the bacteria which he said is a friendly bacteria? There were two he said. Can you just mention any one? Lactobacillus. Correct answer, please.
Thank you, sir. Now I would like to request Dr. Vinita Agarwal to please come forward and felicitate our speaker. Sir, please come forward, Dr. Yogesh Kalra. I request Dr. Vinita to please be on the stage and felicitate our chairpersons, Dr. Kim Maman and Dr. Amit Tulli. I request Dr. Amit Tulli to please give the prize for the quiz to Dr. Kevin. Thank you, sir. Next, for the next presentation, I would like to invite Dr. Nitin Agarwal and Dr. Jasmine Das to chair the session. The next session is by Dr. Aarti Gupta Tuli. She is a senior consultant in obstetrics and gynecology department at Fortis Ludhiana. She had also worked as an associate professor at CMC. She has published numerous papers in national and international journals. She is a lifetime member of Indian Fertility Society, Association of Minimal Access Surgeons of India, Society of Fetal Medicine, the Federation of Obstetrics and Gynecological Societies of India. I invite her to please come forward and deliver her talk on role of artificial intelligence in smart and quick diagnosis of urinary tract infections.
Thank you so much for a wonderful introduction. First of all, I would like to thank Dr. Nitin Agarwal, Dr. William Bhatti, Dr. Umakant for giving me this opportunity. Coming to CMC is like coming to home. And thank you for this opportunity. Now, coming to the topic, role of artificial intelligence in smart and quick diagnosis of UTI. So, from morning only, we are talking about urinary tract infection. And in front of me, big urologists are sitting who day and night, they talk about UTI, they treat UTI. I have gynecologists also, Dr. Kavita ma'am, Dr. Agarwal, who keep on treating UTI now and then. But now imagine in a scenario of medical college, a junior resident, second year junior resident of urologist sitting, and a female comes walking with the symptoms of UTI. Now the third year resident comes. He says, what you will give? The second year resident asks. He says, give nitrofurantoin. SR comes, no, not nitrofurantoin. Give phosphomycin. Assistant professor comes, the third antibiotic. So in previous talks also we discussed first line management, second line management, and third line management. And in previous discussions, there was Dr. Chinmay's talk. Dr. Lydia was talking about MDR. Dr. Joseph was talking about MDR. Now the junior resident is very much confused. Whom to follow? Should the professor come and teach him? Or he's wondering, oh God, maybe I have some tool which can help me in taking the decision, treating the patient to the best the knowledge he has. So now in this few minutes, I'm going to see, you can see the journey of this resident and then the journey of all urologists and gynecologists. Maybe this is the future. So what exactly is artificial intelligence? It is one of the most hot topics that IT industry is hovering around these days. It's how some software think intelligently in a similar manner as an intelligent man thinks. So it's not only medically we are thinking, like from morning we are talking about books, we are talking about evidences, we are talking about societies. So it is where the technology is taking a role. It's accomplished by studying how human brain thinks, how human learn, decide, work while trying to solve a problem. So it's like that artificial intelligence, it's a system that have been taught or learned how to perform tasks without being programmed how to do so. Then the machine learning, and then the deep learning. So what is artificial intelligence in healthcare sector? So it refers to the application of computer algorithms and machine learning techniques for data analysis. So remember, so much of data is there. So many hospitals are there. How to analyze this so vast number of registers, data. So this is how the human error arises. So in analyzing with AI, the human error is definitely going to decrease. Then the second is diagnosis support. What we do, whenever a patient comes to us, we make a provisional diagnosis, 1, 2, 3. Why can't we have a final diagnosis, which will be more appropriately created by this? Then personalized medicine. No, one size fits all. It's not like that. Giving nitrofurantoin on each and every patient. So individualizing, every patient is a different patient. The personalized medicine will be by this. Risk prediction, like AI, not only in UTI, it's more so in surgery. So after the surgery, what will be the complication? Whether after prostatectomy, there will be urinary incontinence, or there won't be. What are the right planes? So the risk prediction is also a more accurate way. Then clinical decision support, and the end result is the final support. So how it works, there is an input layer, there is a database, there is AI layer, then algorithm layer, and then the final output. That is decision making regarding the diagnosis, probability of surgical success, and prediction of cost and payment. So for the benefit of the patient also, and for the benefit of the treating doctor also. So what are the popular machine learning algorithms? They include support vector machine, random forest, gradient boosting, decision tree, artificial neural network. Too much of detail in technology, but in simple words, they are going to help us in analyzing the patient as a whole, as an individual. And what they identify, they create a unique correlation between symptoms, urinalysis, inflammatory process in the urinary tract, and then concise variable sets that are accurate in predicting urinary tract infection. Now, only 2 slides about UTI. Everybody is talking about UTI. It's a bacterial infection that can infect any part of the urinary tract, kidney, bladder, ureters, and urethra. And the diagnosis, we have talked about it, microscopy, then dipstick test, and urine culture, as said, the gold standard. Now, what are the pitfalls in this? UTI-associated urine changes could be present in non-infection urinary tract pathologies like PID, very common in females. Urine culture can take up to 72 hours, 3 hours, And we are talking about MDR, we are talking about overuses of antibiotics. During this time, clinicians often treat patient presumptively based on symptoms and risk factors. And in many cases, those initial drug choices are proven wrong by the sensitivities identified on cultures, leading to a switch on therapy, increasing the cost, increasing the number of visits, and increasing the chances of antibiotic resistance. Moreover, urine culture suffers from several shortcomings, such as highly susceptible to contamination, leading to incorrect antibiotic prescription, overutilization, antibiotic resistance, and then postponement of treatment. Now the wow factor comes for your junior resident. So he suddenly came out with this article of May 6, 2024, that AI algorithms can accurately select antibiotics for UTI up to 3 days before urine culture results are available. Now he has a tool, he has a wow factor. This was a chief finding from a study presented by Cleveland Clinic investigators at the AUA 2024 meeting. And they tested trained algorithms in about 6 million patient cases of resistance to 11 of the most clinically relevant first-line antibiotics used to treat UTI. So data was also very good. And the goal of the new research was to create machine learning algorithms that accurately predict UTI drug sensitivity before urine culture results are available, decreasing time to symptom resolution, minimizing the need for prolonged antibiotic therapy, and reducing patient burden and clinician workload, especially in cases of children when we were discussing. The role of antibiotic resistance, that is really increasing, and infection is also increasing. And the other thing that it decreases the workload in labs. So what happened, they analyzed one of the study, they analyzed 1,000 urine samples, they were cultured and processed using AI to detect bacterial growth. And the results show 100% sensitivity for microorganism growth and 97.53% for E. coli detection. So what the AI proved to be a reliable tool that can significantly reduce the time needed to rule out negative samples. So pathologist doesn't have to run after negative samples and evaluate them more. So the workload automatically decreases in case of AI. The other thing is, I am talking about antimicrobial resistance. What? It occurs when bacteria, viruses, fungi, and parasites, they evolve and no longer respond to treatments that were once effective. A nightmare for every clinician. So this resistance leads to longer hospital stays, higher medical cost, and increased mortality rates, posing a significant threat to public health and potentially rendering common infections untreatable. So traditionally, what is UTI diagnostic test? Whatever the 3 tests, the one-size-fits-all approach to determine which antibiotics are most effective against a specific bacterial or fungal infection. So the AI, the research led by Dr. Alex Howard, a consultant in medical microbiology, he from University of Liverpool, they said that AI models, they test prediction models for 12 antibiotics using real patient data and compared personalized AST with standard method. So every individual will be seen differently. Every individual will have a different sensitivity for antibiotic, and then they will go for that. Now the key points about AI in whole this talk, that is one of the most important, improved accuracy. There is no space for errors. Faster results, no need to wait for 3 days. Predicting antibiotic resistance and patient-centered approach is there. And how AI is used in UTI diagnosing, we are analyzing the urinalysis data, combining the clinical data, and then various machine learning algorithms, they come up. So this is how they work. There is a clinical diagnosis, there is biomarkers, and then AI diagnosis is there in various algorithms it runs, and the benefit is I have already enumerated. But whenever technology comes, we need to take it with a pinch of salt. We need to consider few considerations. We need to be more careful. So the data quality, data quantity, because we know a North Indian and South Indian in India, if we are just studying North Indians and we are not including a population from South India, the results will not be better. So we need to cross the geographical lines, and then we need to calculate. So the quantity is very important. Clinical validation and physician interpretation. Most of all, AI should be used as a decision support tool. It's a guiding tool. It's a support tool, not a replacement of clinical judgment by healthcare providers. So it's not going to replace the doctors. It is just for helping us. The other thing is to facilitate the training models, like I already explained, that it is essential as many medical centers around the world as possible. They converge on a common terminology for UTI, threshold values for various indicators, and research quality. And some ethical issues, they need to be considered whenever we are going for that. That includes patient safety, cyber security, transparency, and inclusivity. So these are the various references I have taken. And my final thoughts are, like AI-driven UTI, it's in infancy. It's an infant level. So, but it's a promising new era of healthcare research. However, it is still in the exploratory rather than the implementation phase. To fully realize AI potential for enhancing UTI diagnosis, more study is needed, ideally guided by larger, more diversified data sets and rigorous validation technique. And when I was going through literature, people are publishing books on AI in urology. So this young man has already published a book on artificial intelligence. So we should see where we stand. So old way or new way. So don't be afraid of change. It leads you to new beginning. Either change yourself or other will change you. So change is a law of nature. Thank you so much.
Thank you, Dr. Aarti, for that wonderful talk. This is a really unique topic. I have never heard of AI in urology or AI in UTI. Specifically.
3 days back, I also never have heard before the topic was given or chosen.
Yeah, but you made it very simple, so we at least have some understanding of AI in urology.
Thank you.
My question to you is, like, do we have any app, AI app, where we can feed all the data and we get the answer?
This is what is coming up. Like, this is what, that they will fill everything, and then different algorithms which are already designed, seeing the data of the previous patients. Like, there millions of urinalysis will be there. There will be the, was the complaint of the patient, what was the urinalysis in that, was there any resistance to any antibiotics. So when they are fed, then the person who is going to add the information about some different patient, that information will come, that in previous patient, how this thing worked. So this is how it is going to guide.
And will
At present, I don't think so, but maybe I'm in Ludhiana. People in South, they may be like, we had Dr. Francis from Hyderabad. We have people from CMC. So maybe they may know better than me, because I'm also new, whatever I said.
And AI probably will help in doing tests in lab also, that is also
in diagnosis, it was new, but in surgery, it is definitely helping. Like, I'm in a surgical branch. The AI assist in robotic surgery. Like I said, that if you are doing robotic prostatectomy, they will give you the prediction that this patient is going to have incontinence or not. They will identify the planes. You go in this plane, you go in this plane. So it's going to help. But it is not going to replace. It is going like a MRI. I did a PV, I found a mass, but I'm not able to make out this is what kind of mass. MRI came into picture, CT, they help us, but they don't replace us. But then my treatment will be best for the patient.
It cannot replace the clinical judgment.
Yeah, this was like, even when I was going through, I was thinking, now what will happen, radiologists, what they will do. Like radiology, it's coming very, very fast in radiology. So what are they? One of my friend, she's into this. But then she only told me that no, it is not going to replace, it is just going to support us. That is why I mentioned that also.
So Dr. Aarti, nice talk. And whenever a new technology and new concept comes, there are in fact 3 phases of any. When laparoscopic surgery came, initially there was a phase of denial. Oh, no, this is not my cup of tea. I cannot do this. So I think AI is coming in a big way. We cannot live in a denial mode. For good time we spent in a denial mode, we should try to adapt it. And there are 3 phases. First is denial. Let me try, I'll do it. And after some time, we will teach other person.
I fully agree. That is why, sir, I said either change yourself or others will change you.
So
you need to change.
So enough time we spend in denial mode. I think we should adopt AI. And thank you very much for nice talk.
Thank you so much.
Any other question from the audience? Yes, please.
Hi, Dr. Dhruv. Thank you for coming and listening. I'm honored. That's what I'm saying, that maybe I'm in Ludhiana, I'm not in a very forward place, but you had come from...
I'm sure all of us, and I do follow Dr. Google quite a bit, it's quite useful. The only thing that I know a lot of that references come from countries in the West, in high-income countries with lower populations and uniformity of healthcare. So the thing to be sort of cognizant of in our setting in India is that AI is built on data sets, large data sets. It's built on algorithms which come out of those data sets. And so you have a uniformity in collecting that data. Unfortunately, in our country, we do not have uniformity in healthcare data. So we don't have a uniform HIS across the country, across states. Even in Ludhiana, even within hospitals, you have different HISs. So the thing probably for all of us to think eventually, and the government of India has an HIS system which is trying to have it in all our hospitals, both private, charitable, or government, is for us to think about adopting similar HIS system where we can collect the data. Because what happens with UTI, the data that we collect in CMC is not the data that we collect in your hospital. Similarly, the methods we use to diagnose UTI is not the same everywhere else. And so when that happens, and everything else will be very different in Francis's place in Hyderabad or Partho's place in Vellore. So when that happens, you have very diverse data sets. And diverse data sets don't make for good algorithms. And when you don't have good algorithms, you have a dangerous AI, which is actually going to harm patients. So probably all of us have to start seriously thinking about the government's initiative of having the same HIS across the country. And that will help us. And AI will be most useful in low and middle income countries, not in the West. The effect of AI will be seen most in our setting, in our rural hospitals, etc., where there is lack of manpower and resources. So unless and until in our country, we get our act together, AI will be harmful. And it's very important for us to get an act together. AI is the future. In fact, AI is the present right now. I think a lot of, if you look at the last short grants given out by the ICMR, almost 20% of the grants have been given for AI research.
Correct.
And
it's
a
the
lot
most
of
upcoming branch which is coming even in IT sector.
Yeah. And unfortunately, the healthcare research in AI is being done by IITs, not by medical schools. So that is something to look for. The doctors should be thinking about that. Thanks a lot.
Thank you so much.
Thank you very much, Dr. Aarti. I think all people are feeling hungry. Let's have a small lunch break, then we'll meet.
we'll just felicitate the speaker and the chairpersons, and then we'll proceed for lunch. I request Dr. Amit Mahajan to please come forward to felicitate our guest speaker. On request, Dr. Kim Maman, please join Dr. Aarti and Dr. Amit. Thank you, sir. Now I request Dr. Amit Mahajan to please felicitate our chairpersons, Dr. Jasmine Das. Thank you, sir. Now we proceed for lunch. Lunch is served. Everybody please proceed towards lawns near the blood bank for lunch. Thank you. We'll be gathering together back after half an hour. Thank you, everyone.
So there are first year.
तो फिर मुझे कैसे बुलाएगी, तू कब बुलाएगी?
Kevin already took the prize, huh? So we'll begin with the Euro quiz. We have 5 teams here. I request Dr. Amit Mahajan, who is our quiz master for the day, to please come forward and conduct the quiz.
So good evening all. Welcome to the main event, much awaited event of Euro quiz. So the details of what are the rules. We have 5 teams here, which is sitting on the left side, and audience will be sitting back on the right side. And rules will be explained by Mukul. He will tell shortly the rules to the teams also and to the audience also. We have a lot of prizes, big prizes for all of you. Just be sincere to the quiz, to the answers. See carefully and answer accordingly. And the result will be declared at the end of the quiz. Okay, all the best, guys. And this side also, all can participate. Faculty can participate for the quiz also. In the audience poll, not in the main quiz. Okay, so I'll hand over to Mukul, please.
Okay, thank you, sir. So there will be a total of 30 questions. You will be given 45 seconds for each question. You have to record your responses in your answer sheet. In the end of the quiz, you have to hand over your answer sheets to us. Okay? So you will get 45 seconds for each question. We will display the question over the slideshow, and you have to record your answer in your answer sheets. So make sure all of you have written your names on your answer sheets. So shall we begin with the quiz?
Are you ready? Say yes. Okay, they are ready.
In between, we'll have some audience questions. So question number 1. An adult male patient presented with acute onset of genital and perianal pain and foul smell along with signs of localized tissue necrosis as shown below. Systemic symptoms such as fever and leukocytosis are present. Which of the following are not included in management of the patient?
30 to 45 seconds only, huh?
Yes, sir.
Last 10 seconds. Time's up.
Coming on to next question. So, which finding in an adult is most likely to require immediate management during the primary survey? Option A, distended abdomen. Option B, Glasgow Coma score of 11. Option C, temperature of 36.5 degrees Celsius. Option D, a respiratory rate of 40 breaths per minute.
ATLS question, advanced trauma life support. I've given you the hint also, ATLS question.
Question number 3. A 45-year-old male presents with abdominal pain, hypertension and recurrent UTI. On examination, bilateral flank masses are palpable. CT KUB reveals enlarged kidneys with multiple cysts bilaterally as shown in the image. What is the most likely diagnosis? A. Polycystic kidney disease. B. Hydronephrosis. C. Renal cell carcinoma. D. Tuberous sclerosis. Coming on next question. A 45-year-old male presents with decreased urinary stream and recurrent UTI. Investigation revealed a narrow segment of 1.8 cm in anterior urethra, consistent with urethral stricture. What is the management of this patient? A. Urethrotomy. B. Insertion of Foley's catheter. C. Excision with end-to-end urethroplasty. D. Urethral dilatation. Question number 5. A 45-year-old female presents to casualty with severe flank pain and nausea. On physical examination, her BP is 150 by 90 mmHg. She has tenderness over right costovertebral angle. USG reveals dilatation of right renal pelvis and calyces with parenchymal thinning. What is next step of management? Next, we have a question for the audience. Please be ready. So you have to identify this personality and what he is famous for. Anybody from the audience? We have a book, sir. Yes, Partho, sir. Absolutely correct, sir. What is he famous for?
He invented the Foley's catheter.
Yes, sir, yes. Absolutely correct. So next question for the participants. A 55-year-old male presents to ED with complaints of fever, chills, dysuria and perineal pain for past 2 days. On examination, his temperature is 101.8 Fahrenheit. There is tenderness on rectal examination. Lab investigation revealed leukocytosis and serum PSA level is elevated. Urine analysis shows pyuria and bacteriuria. What is next step in managing this patient? A. Start antibiotics. B. Renal examination of PSA levels. C. Prostatic massage for pain relief. D. Reassurance. Next question. Pain associated with stone in the ureter is a result of A. Obstruction of urine flow with distension of renal capsule. B. Irritation of the ureteral mucosa by the stone. C. Excessive ureteral peristalsis in response to obstructing stone. D. Irritation of the intramural ureter. Next question. A 45-year-old male presents to the ED with severe colicky right flank pain radiating to the groin for past 6 years. He has history of recurrent renal colic. Abdominal examination reveals tenderness over right costovertebral angle. Urine analysis shows microscopic hematuria and the microscopic findings are shown in the image. What is the diagnosis? A. Calcium chloride stones. B. Calcium oxalate monohydrate stones. C. Calcium oxalate dihydrate stones. D. struvite stones. Next question. The most common cause of gross hematuria in a patient older than 50 years is A. Renal calculi. B. Infection. C. Bladder cancer. D. Benign prostatic hyperplasia. Question number 10. Following a motor vehicle accident, a 35-year-old male presents to ED with lower abdominal pain, hematuria, difficulty in urinating. On physical examination, there is suprapubic tenderness. Urethral injury is ruled out. Which is the most appropriate next step in management? A. Perform immediate surgical exploration. B. Administer broad-spectrum antibiotics. C. Order a CT scan. D. Insert a Foley scatter and obtain a cystogram. Now, audience question. Can you tell me which size Foley scatter is this? Next audience question. Pranay sir, identify the instrument. You guys can also give the answer here. We'll give you a book. Yes, Shivam. What Satinsky? Yes, right answer. Next question for the participants. A 60-year-old male presented with complaints of increased urinary frequency, nocturia, and difficulty in initiating urination over past 6 months. On DRE, his prostate gland was found to be asymmetrically enlarged with palpable firm nodules and irregular borders. Which of the following markers of prostate cancer is most commonly used for diagnosis? A. PSA, B. Alpha methylacyl-CoA racemase, C. Prostate cancer antigen 3, D. Prostate specific membrane antigen. So next question. The first maneuver to improve oxygenation after chest injury is to A. Intubate the patient, B. Assess the arterial blood gases, C. Administer supplemental oxygen, D. Assert the need for chest tube. Next question. A 2-month-old male infant presents with poor urinary stream, dribbling of urine, and a palpable bladder. There is a history of prenatal hydronephrosis detected on ANC ultrasound. Physical examination reveals a distended abdomen with palpable bladder, and on digital rectal examination, a high riding prostate is noted. What is the most likely diagnosis? A. Posterior urethral valve, B. Vesico-ureteric reflux, C. Uterop, UPJ obstruction, D. Bladder diverticulum. Next question. The most common cause of pain associated with gross hematuria is A. Simultaneous passage of kidney stone, B. Ureteral obstruction due to blood clots, C. Urinary tract malignancy, D. Prostatic inflammation. All of the following are typical lower urinary tract symptoms associated with BPH except A. Urgency, B. Frequency, C. Dysuria, D. Weak urinary stream. So, a question for the audience. Which of the following UTI is a common risk factor for squamous cell carcinoma of bladder? What? Wrong. ठीक है. Right answer? So next question for the participants. The most likely cause of continuous incontinence, that is loss of urine at all times and in the all positions, is A. Antrovesical fistula, B. Non-compliant bladder, C. Detrusor hyperreflexia, D. Vesicovaginal fistula. Next question. All of the following are potential causes of an ejaculation except sympathetic denervation, pharmacological agent, bladder, neck and prosthetic surgery, CVAs, cerebrovascular accidents. Next question. Which of the following medications is associated with increased risk of UTI in men? Amlodipine, glycopyrrolate, lisinopril, semaglutide. Next question. Which of the following is true about prostate? A. Most prostate cancer is from the transition zone. B. Most normal volume is in the peripheral zone. C. The primary blood supply is from the superior vesical artery. D. The average volume in a young male is 50 cc. Question number 20. Normal voiding is dependent on all of the following nerves except A. Pelvic, B. Hypogastric, C. Obturator, and D. Pudendal. So next question for the audience. You have to identify this personality and name one of his famous inventions. Anybody? Shefin? Shefin? Yes. Louder. What Fogati? Full name? Dr. Fogati. Okay, so this is Dr. Thomas Fogati. Inventions is Fogarty's embolectomy catheter. So next question for the participants. The first laparoscopy was done by A. Using a vaginal speculum introduced through the fornix, using a cystoscope through a subumbilical incision, using a hollow reed through a subumbilical incision, or none of the above. Question number 22. The cause of stricture from a radiation bowel injury is A. Fibrosis following mucosal injury, B. Obliterative endarteritis, C. Fibrosis following necrosis, D. None of the above. Next question. Ulcerative colitis is characterized by which of the following? A. Transmural inflammation. B. Perianal disease. C. Malignant potential in first 5 years of disease. D. Cryptabscesses. Next question. It's a long one. A 17-year-old male presents to ED complaining of sudden onset severe left testicular pain. He reports that pain started about 2 hours ago and has been progressively worsening. He denies any history of trauma to scrotum. On examination, left scrotum is notably swollen and erythematous. The left testicle is tender to palpation, elevated, and appears to be positioned higher than the right testicle. He complains of nausea but denies any urinary symptoms. There is absence of cremasteric reflex on left side. What is the most likely diagnosis? A. Epididymitis. B. Testicular torsion. C. Cauda-Equina syndrome. D. Priapism. Last question. What important information is gained from pelvic bimanual examination that cannot be obtained from radiologic evaluation? Option A, presence of bladder mass. Option B, invasion of bladder cancer into perivesical fat. Option C, presence of bladder calculi. D, mobility fixation of pelvic organs. So coming to last audience question. So we have to identify the procedure shown and what is this surgery done for? Doctor, there are two questions, two options with chronic pancreatitis. Who wants to? No, audience from anybody from audience. Sir, can I take Who here? Jasper? First you have to tell which is the procedure. What is the procedure shown? Okay, it's right, sir. And what is this surgery done for? Both have to be correct to win the prize. Who told? It is wrong, by the way. Yeah, C is correct answer. Next question. मैंने ले ली शीट बस ठीक है ऑडियंस question. Okay, so conditions that decrease urine specific gravity include all of the following except A. Increased fluid intake, use of diuretics, decreased renal concentrating ability, D. Dehydration. Anybody from audience? No, this is audience question. Yes, sir. And dehydration is the correct answer. Okay, so this marks the end of the quiz. Now you submit your sheets for evaluation. Yes, sir.
So we come to an end to the Lobo Oration today and to the Euro quiz. I want to give the vote of thanks on behalf of the Department of Surgery and Urology. It's been a great day today. We can see a lot of participation which faded towards the end of the day, but we realized that it went very well in the morning. And we've looked at all the students who've made a lot of effort, our postgraduate students, to make this a success. So this is the person who has been working all the while. So a round of applause for him, Dr. Rubin. He single-handedly has organized, and we just had to guide him. We've put this up because you have to understand we don't want him to go far from CMC. Yeah, he can go to do his urology MCH, but other than that, he should come back. So I would like to thank all the postgrad students. You have done very well, and you've made this a great success. To the members of the Lobo Trust, thank you, sir, Mr. Maninderjeet and Dr. Kim. We thank all those who were there in the morning, and I would also like to thank all the faculty who has traveled across states. We've seen Dr. Partho, Dr. Umakant, who also, and Dr. Francis Sridhar. So round of applause for them. Thank you for coming here and making this a success. Dr. Anuj Jain, you are still at home, and you're most welcome to visit us anytime. We're looking forward to you sharing your knowledge with us, and to everyone who participated. Special thanks to APL Apollo Group, Mr. Sameer Gupta and Sanjay Gupta, I think I got them right, for supporting this quiz part. The quiz, the gifts were all supported and sponsored by this group, and this along with them being a part, they are now kind of attached to CMC Hospital Ludhiana, because Dr. Nitin Agarwal has been in very close relationship with them by treating the family member. And even today, he's going to be operating on one of their relatives. So we are really thankful to them, particularly for sponsoring this entire event. And to everyone else who has been silently working behind the scene, the admin, the principal's office, and the director's office. Bye, everyone. Have a good day. Thank you.
I request Dr. Nitin Agarwal to please come forward and felicitate Dr. Partho. I think he involved the audience a lot, but we really forgot him. So last but not the least, I think Dr. Partho deserves one felicitation from all of us. I request Dr. Nitin to please felicitate Dr. Anuj Jain also. I know we couldn't have his case discussions, we were looking forward to it. वो रूबेन सर पीछे हम आपकी बात को बदल लेने के रंग बता दो. I request Dr. Nitin to also felicitate Dr. Amit Mahajan, who was the quiz master for the day. Pranay sir, please cheer up, at least you should do. I request Dr. Nitin Agarwal to please felicitate Dr. Parvez David Hug, who helped in organizing this event and making it a success. Thank you so much, sir. Simran and Jasper, both of you can come and collect the book. I think you can both read from it. If you want. Simran, come forward.
चलो आओ जल्दी आओ सिमरन and Jasper. You give. Please take the book. Divide in two pieces, huh? Three.
Okay, now the most awaited time for the results of the Euro quiz. Dr. Amit Mahajan will announce those.
So Euro quiz results are ready. we have taken first 3 teams. So we'll start with the third team first. Okay, the third team, I will not tell the marks, just the third team is Dr. Parth and Dr. Raj. Sumit.
Dr. Maninderjeet, Dr. Kim Mamin. Sir, please join us, sir. This is the last event. Dr. Nitin Agarwal to please come and give away the prizes to the winners.
So second team, any guesses? Second team? Second in?
Manish.
अभी
आया नहीं
नहीं है. Any guess? That was guess. मैं क्या सीखा रोटी कट का. Second is Dr. Mega and Dr. Stephen. So the team with the first prize, and they have almost got the whole, not almost, but they are maximum scorers. Any guess?
Manish. It has to be Manish. First year, it has to be a first year.
Okay, Dr. Ishan and Dr. Manish. Okay, thank you so much. Thank you.
Thank you so much, everybody, for making this event a success.
Sir, we have for the other 2 teams also, please come forward and take the concession prizes, please, for the participation. Please come.
Kevin, Gurpreet, Jivin, and Vinay, please
Yeah,
come
please come one by one as a team.
Sir, wo wrapping kar- Thank you, everybody, for joining us for the event. Thank you so much. One department photo will take. One Manish photo with books also will take. Rare sight to see. Please gather for one department photo.